To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Program studi spesialis anestesiologi dan terapi intensif berada di bawah naungan Fakultas Kedokteran
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic feeding scenarios. Rotor provides a global assessment of hemostasis by using a saturated whole blood sample. So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the POCT recommendations. First, take out one level of QC material, rotor N or P, and let it reach the room temperature. Dissolve the content of rotor P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotor and scan the rotor vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement. Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenario. Proton provides a global assessment of hemostasis by using the saturated whole blood sample. So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the POCT recommendations. First, take out one level of QC material, rotor L or P, and let it reach the room temperature. Dissolve the content of Rotrol P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotrol and scan the Rotrol vial. Open the pouch and insert the cartridge in the device. Insert the Rotrol vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other Rotrol QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of demograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Roto Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenarios. Roto provides a global assessment of hemostasis by using a saturated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and tomograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the BICCM recommendations. First, take out one level of QC material, rotor N or P, and let it reach the room temperature. Dissolve the content of rotor P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotor and scan the rotor vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find out to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenarios. Rotor provides a global assessment of hemostasis by using the saturated blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the BICCM recommendations. First, take out one level of QC material, rotor N or P, and let it reach the room temperature. Dissolve the content of rotor P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotor and scan the rotor vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacuum drainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenarios. Rotor provides a global assessment of hemostasis by using a saturated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the POCT recommendations. First, take out one level of QC material, rotor N or P, and let it reach the room temperature. Dissolve the content of rotor P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotor and scan the rotor vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenarios. Rotor provides a global assessment of hemostasis by using a saturated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the BOCT recommendations. First, take out one level of QC material, rotor N or P, and let it reach the room temperature. Dissolve the content of rotor P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotor and scan the rotor vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya. Greetings of welfare. Peace be upon us all. Ladies and gentlemen, welcome to the guest lecture, Bali Combined Clinical Meeting 2025. It is an honor to stand before you today as we gather to celebrate this momentous scientific event. First and foremost, let us express our praises and gratitude to the presence of Ida Sang Hyang Widiwasa, the Almighty God, for it is by His grace that we gather here for this guest lecture. Allow me to introduce myself. I am Jonathan. I will be guiding the proceedings on this joyful event. And before we commence, I would like to extend the greetings to our esteemed teachers and the invited guests who have joined us in this moment. And also, we would like to express our gratitude to PT Satya Ananta Parma for supporting today's guest lecture. Prior to this today, Bali Combined Critical Care Meeting have been conducted 11 times before. And these events have not only given us valuable insights, but also have inspired us to strive for excellence and innovation in our respective fields. Ladies and gentlemen, esteemed guests and participants, as we gather here today for this guest lecture, let us begin by invoking the spirit of unity and diversity that our national anthem Indonesia Raya embodies, and continue with our hymn song for Bali Anesthesia. May I kindly request everyone in this room to rise up for our national anthem. Guest lecture. Prof.
Yeah, yeah. Okay. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, namo buddhaya. Salam sehat, salam kesejahteraan. Selamat siang, sahabatku semua. Dr. Anu Raju, Sam, Dr. Kim, David, and Laura. Welcome one again in Bali. Welcome in this classroom. And I want to introduce that all of the agents come from the anesthesiologists. Maybe some of them follow the fellowship of ICU, and most of them is a registrar, our registrars, and also maybe in the year our medical student. Okay, so as you know that every semester we receive 20 registrars. So that's a year's 40 registrars. So that's why we have a lot of registrars for today. Okay, so I think for the new registrars, I have known Dr. Anu, Kim, and Sam. Maybe the other, David and Laura. Is it the first time Kim here? Oh, okay, thank you once again. Okay, so for the audience, it's a long-standing collaboration between Women and Children Hospital and Adelaide University with the Udayana University and our hospital, Ngurah Hospital. And 12 years ago, I'm really happy that anesthesiology was involved in this collaboration. Said in this long-standing collaboration, honestly, I would like to say that a lot of benefit for us to improve our services in the field. So Anu and friend, my friend, every year came in this classroom, and always, I don't know why, how many times Anu came also in Sam with Zoom meeting with our registrar. I don't know, every 6 months or every year or so. So that's why my best friend from Australia, along with traveling from Australia, always give us a contribution, a lot of contribution for us to improving our services in the field. So in this 12 years ago, we have agreements with the two institutions, another a mutual benefit for us. Of course, we realize that we have a lot of benefits for this collaboration. So in this meeting, in the 12th meeting of the BICCM, I'm happy that's one topic that most important for us is about nutrition support. It is very useful for us because you know that as we know that our ancestors said, Hippocrates, more than 2,000 years ago, more than like that, said that the best medicine is nutrition. So, and then our clinical nutrition department in this hospital report that a lot of patients came in this hospital with a sign of malnutrition. And also they said that, and they report about that, most of the patients also malnutrition in hospitalized patients. That means that sometimes we forget about the nutrition. She just focus on the disease like that, so we forgot about the nutrition support. The secondly that I'm really happy for this meeting is about bleeding tendency. Although you're talking about especially in the OBGY. Nowadays we still a lot of placenta accreta like that. We have a lot of traffic accident with brain trauma, blunt trauma, fracture like that. So that is a sign of bleeding for this patient. A lot of bleeding, as you know, if sometime or someday you visit our ICU and our intermediate care, a lot of brain injury, a lot of trauma in that patient. So that is a sign of bleeding tendency. But unfortunately, I will to say that in our field, it's still difficult for us to find coagulant factor. So if you read about the protocol massive transfusion, one thing that was important is the seventh factor like that. So we don't have, it is very difficult for us for like that. So that's why everything, that every time that we just give red blood cell, plasma, fresh frozen plasma, thrombocyte, and sometimes we use also tranexamic acid as the antiparabolic agent. That's all that we can give for all the patient. So I think that this moment for all the registrar, the expert from the abroad will be with us to talk about the massive protocol transfusion like that. So we hope that in this moment, a lot of discussion, a lot of question from the audience to the expert. So I hope that in this meeting, all the speakers will speak about that, and that's why. So I hope once again that all of you preparing the question, and I think we hope that we have a lot of conclusion of this meeting to improving our services in the field. So once again, on behalf of the study program and Department of Anesthesiology, I would like to express to all the speakers, my best friend from Australia, who came in here with us always. So for all of you that it is important for you as anesthesiologist, and also for the medical student also, sitting here with us to discuss about this meeting and a topic like that. So once again, thank you very much for Anu, Sam, Kim, David, and Laura. Once again, terima kasih banyak. And I hope that it is not the last time that you came in this room. Terima kasih. Selamat berdiskusi, selamat berseminar. Sekali lagi saya hanya mohon banyak tanya sama beliau itu. Beliau ada expertnya, saya kira bebas mau tanya apa saja. Terima kasih banyak.
Thank you. Thank you, Prof. Madewira. Now, please join me to hand over a token of gratitude by handing over an authentic Balinese gift for our speakers. Let's take a group photo real quick. We'll be facing right here to the committee. We'll be facing right there. Yeah. Okay, look at the middle camera. 1, 2, 3. Cheese. Different pose. Okay. 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 Today we are going to hear an in-depth discussion from several guest lecturers, our visiting professors, Dr. Anuraju, Dr. Kim Osborne, Dr. David, Dr. Laura, and Dr. Sam Lam. All sessions will be moderated by our respected teachers, Dr. Othniel Adrian Slabobar. Without any further ado, I would like to hand over this session to our moderator, Dr. Othniel.
Thank you, Dr. Jeremy. Okay. Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh. Shalom, salam kebajikan, salam sehat untuk kita semua. Good day, ladies and gentlemen. My respected senior, the guest speaker and the participants. I would like to welcome you all to this guest speaker presentation. There will be 3 presentations of 20 minutes each, followed by 15-minute discussion. And after lunch, there will be another 3 presentations of 25 minutes each, followed by 15 discussion. The first presentation will be overview of obstetric anesthesia by Dr. David. The second presentation will be a bit of history and what's new in obstetric anesthesia by Dr. Anuraju. The third presentation will be management of hypotension during cesarean section by Dr. Sam. The fourth presentation will be massive transfusion protocol for pregnancy patient with Acreta Totalis by Dr. Yudi Pratama. The fifth presentation will be algorithm and transfusion decision guiding with Rotem by Dr. Kim. The sixth presentation will be management of failed neuroaxial by Dr. Laura. And now, Dr. David, I invite you to start the first lecture.
So I did an obstetric fellowship about sort of 4 years ago, and then I was married to an obstetrician, so I figured I couldn't escape obstetric anesthesia. So I thought I'd give a talk on the overview of it. So we turn next slide. So I thought I'd break it down into the sort of principles of sort of how you can manage analgesia during labour. And so the first way I thought would think about it is either you have drug options or non-drug options. I won't talk really any more about the non-drug options because as anaesthesia people, we're drug people. But there are some of the options like massage and bath and TENS machines that we can use. In terms of the drug options for managing pain during labour, sort of the most commonly available one that we have is nitrous oxide, which is in all of our labour wards. And how nitrous oxide works, it's an inhaled anaesthetic gas, pretty similar to sevoflurane and isoflurane and desflurane in terms of how it works. it also has some analgesia properties which make it quite useful for the labouring process, but it's hard to give an unsafe dose. The patient can still generally stay conscious throughout while using it. In terms of how it works, we don't really know. We think it works on some of the opioid receptors, some of the NMDA receptors, and also by GABA receptors. And the plus sides of it for labour is it works very quickly, so it can work within about a minute or so, and it wears off very quickly, so it's quite safe from that aspect. And it's safe to use in the vast majority of patients, but it is with the caveat if someone's severely malnourished, they potentially are at risk of B12 neuropathy, which might be something to consider as well. And then the other options that we commonly use for pain relief is opioid medication. And these are generally how we would use it in Adelaide, would be in the form of subcutaneous fentanyl. And the doses can be anywhere from 50 micrograms up to 200 micrograms, up to 1 hourly. They are very large doses, but it is in a controlled situation where they're one-to-one monitoring and the ability to give naloxone if needed, if there's overdose. It works well as a pain relief medication. It is dose dependent, but it has lots of side effects, which I'm sure most of you know about. It can make the patient quite sleepy. It can make the patient quite nauseated. It also can make the baby quite sleepy and risk neonatal respiratory depression when they're born. And you never get full pain relief through opioid medication. The other options, PCAs or patient-controlled analgesia, I won't go and talk about that because I believe Arnie's going to be talking about that a bit later. Next slide. And then where we really get involved as anaesthesia people in the form of regional anaesthesia. And so to give an example or to give an idea of sort of what we do for labour and the patients get epidurals, I'd say only about 30% of patients having a baby will have a caesarean section, and the rest of those, so about 70% of patients, will either have a normal delivery or an instrumental delivery. Of those 70% of the patients, it depends on the hospital, but it's anywhere from 60 to 90% of those patients will get an epidural. So we've fortunately got the ability to provide it as a service for basically every patient that asks. The benefits of an epidural is it's basically the only way to completely get rid of pain during labour, and it's very effective in the vast majority of patients. And then compared to using opioid medications, it generally has better pain relief. The baby comes out more awake because there's less to no opioid medication in their system. The reasons why we'd do an epidural during labour, the main one is if the mother requests it. We'd also consider it if there was, say, twins pregnancy and there might be a need to run to theatre quickly, or if there was any maternal condition where we want to prevent any significant sympathetic stimulation. So aortic stenosis would be one of the main ones that we would consider to blunt that sympathetic response during labour. In terms of why we wouldn't do it is so if the mother specifically refuses it. If there was an allergy to the local anaesthetic, fortunately it's very rare to be truly allergic to amide local anaesthetics. The main ones that we would use would either be ropivacaine or bupivacaine. If there's an infection over the site of insertion, such as cellulitis, we definitely would not do it. If they were hypovolemic, so they were fluid deplete, we wouldn't do it because of the potential blood pressure drop when we institute a sympathetic blockade. If they were coagulopathic, so if they were on heparin or if they had severe preeclampsia with low platelets, we wouldn't perform that. And if it was in labour, we would consider, say, the opioid medication, or if they need a caesarean, we'd consider a general anaesthetic in those situations. Or if they had a condition of raised ICP, where if we accidentally performed a dural puncture and dropped that ICP, that could be catastrophic. We wouldn't perform it. In terms of why we would be wary of giving it, if they thought their likelihood of significant hemorrhage, and by having an epidural block on board, they'd be less able to tolerate that drop in blood pressure. If they had an untreated systemic infection, such as chorioamnionitis, we would be wary of doing it because of the risk of seeding bacteria into the epidural space, or they become shocked and have an epidural on board. And I know I mentioned aortic stenosis as a reason why we definitely want to do it. We would just be wary of instituting a large sympathetic blockade quickly with somebody who had aortic stenosis because of the potential drop in afterload to their heart. So we would just be a gradual onset if we were planning on doing it. And if they'd had previous back surgery, so the common ones being a microdiscectomy or a laminectomy, or if they've had scoliosis and a fusion, we would be wary of doing it because the epidural still can work, but it might be patchy or might not get full efficacy, and they'd be at higher risk of complications such as a post-dural puncture headache because they might have altered anatomy. That being said, in those patients, a spinal block should still work effectively without any issues. A bit of the anatomy, which I think is helpful if those that aren't used to doing it or are new to it, to describe the differences between epidurals and spinals, because I've heard some people like obstetricians and midwives use the term interchangeably, and as anaesthetists we know there's a big difference between the two. So epidural, the epi being around or outside, and the dural part being the dural sac, so it sits outside of the dura. The main benefits of that is that we can leave a catheter in, so it allows us to continually add more local anaesthetic, and that catheter can stay in our institutions up to 7 days. Say if it was abdominal surgery, obviously a labouring patient would not be going that long. The other option is a spinal anaesthetic, so this is going past the dura into the CSF and putting local anaesthetic directly into the CSF. It's very effective because you don't have to rely on the spread in terms of diffusing through the epidural space, but it is generally a single shot, so you're time limited from when you insert it. You've generally only got a few hours before it wears off, and you have no ability to top it up, unlike an epidural. The anatomy that's relevant is in the vast majority of patients, the spinal cord itself will end at roughly L1, but that dural sac will extend all the way down to the sacrum. So you've got that sac that doesn't have the spinal cord that allows you that margin of safety. So if you're doing a spinal or an epidural, you shouldn't be at risk of hitting that spinal cord if you accidentally went too far, but you can still get to that dural sac and put the local anaesthetic directly into the CSF. And the epidural space doesn't have too much in the way of contents, it's more of a potential space, but it does have the venous plexus, which is a potential risk of bleeding. The way that we sort of perform it is we do what's called a loss of resistance technique. So we have a special needle, like a 2E needle, and we have a special syringe that detects pressure changes. And we're trying to find that potential space where there's going to be low pressure in comparison to, say, fat or ligament, where there's high pressure to inject through. And it's a blind technique, and you're not seeing where your needle is, you're just reliant on pressure changes through the syringe and the needle itself. Once you get to that space, you thread a catheter through the inside of the needle, and then you take out the needle, and the catheter is the only thing that stays inside, and that allows you, with that catheter inside, you can continue to feed in more local anaesthetic. There are limitations with it. Sometimes you can get a patchy block or a unilateral block where it only works on one side of the body, and we don't always know why that occurs. It can sometimes be scar tissue or whether the catheter has thread. In terms of the anatomy, so that's what you're aiming for, that lumbar spine, and really the positioning, what we try to do is turn that what is a normal lumbar lordosis into a kyphosis through positioning, and that the aim of that is to hopefully open up the spaces between those spinous processes, which if you go to the next slide, you should see the positioning for that. So it's that hunch forward positioning, it's that lower part of the back that they're trying to sort of bend out to increase the space between those spinous processes. And that's an example of how someone's chosen to hold the 2E needle, and they've got a loss of resistance syringe that they're detecting through that right hand. The pressure changes to see if they're in that epidural space. And that's an example of what the needle looks like. So we routinely use a 2E needle for epidurals. It's a hollow needle that we can feed a catheter through. There is a risk with this procedure, so if you go too far and you puncture the dura, you might be performing a spinal anaesthetic unknowingly, which has its own issues in terms of you can get a very significant block quickly. If you use large doses of local anaesthetic, you potentially can give them a total spinal anaesthetic and also drop their blood pressure profusely. And you can get a post-dural puncture headache, which I'll cover a little bit later. And so the main reasons why we would use an epidural, so it's for labour analgesia, so particularly if the patient requests it. We also, in non-obstetric situations, could use it for post-op analgesia as well. We routinely use a low concentration of local anaesthetics. The institutions I work at, it's usually 0.1% ropivacaine. Some places it's 0.125% bupivacaine, and some areas are going as low as 0.065% bupivacaine. The idea being that lower dose of local anaesthetic, you can still get good analgesia, but you don't get the motor blockade, which is going to affect their ability to push and delay their labour and increase the risk of forceps. And so by dropping that dose, you can essentially give pain relief without impacting their labour. We can also, if the epidural is working well and the patient needs a caesarean section, we'll generally transition over to a high-strength local anaesthetic. So either like our usual ones are 2% lignocaine with adrenaline or 0.75% ropivacaine. That gives a very heavy motor block and also significantly numbs them from an anaesthesia point of view so they can undergo a caesarean section. And then spinal anaesthetic, so it's quite similar to a lumbar puncture in that you're inserting a needle to go all the way through past the dura. The differences between a lumbar puncture and a lumbar puncture you're taking out CSF, a spinal you're putting in usually local anaesthetic. And we use a very small needle for that. The reason why a very small needle is we want to create as small a hole in the dura as possible, because the larger the hole, the more likelihood of causing a post-dural puncture headache. And we generally only need to inject down a few mils of local anaesthetic. The downsides of the small needle, it can be you get less feel through the needle, so it's more likely to bend or flex compared to the 2E needle. The spinals produce a rapid onset of a dense block, usually in the range of 1 to 3 minutes, as opposed to an epidural where it can be sort of 10 to 20 minutes to achieve a similar style block. And we generally use for caesarean sections a hyperbaric solution, which I'll cover a little bit later, to allow us to titrate the block height. The benefits of spinal is because it's directly into the CSF, you don't have to worry about scar tissue, so you generally get a very effective block that's even on both sides. But as I said, it is time limited, so once it's inserted, you've only got a few hours generally before it wears off. And then the other alternative, which we occasionally do, is a combined spinal epidural, and you both do a spinal injection and use an epidural needle to thread an epidural catheter. It can be seen as the best of both worlds in that you get a rapid onset spinal block and you have the ability to extend it with the epidural catheter. You can either use a special kit that's designed for it called a CSC kit, or just a standard 2E and a long spinal needle, like I say a long Whittaker needle, because you need that extra length to be longer than the 2E needle itself. And the main uses for that is if you think that the caesarean section is going to go longer than a standard spinal, so if they'd had a number of caesarean sections previously. The drawbacks, it's harder to do, it's more complex, there's more things that can go wrong, and it's a fiddlier procedure which you might not do regularly, which can limit your ability to do it quickly and effectively. And that's the top left is the kit they sort of use for it, that we use for it. It's a specially designed kit. It's a 2E needle, but it's got a spinal needle designed to insert and lock off so that you can perform your spinal injection. But otherwise, you could just use a standard 2E and a long Whittaker needle. And that on the bottom is just an example of how the needle comes out, the sort of the tip of the 2E needle to perform the spinal itself. And then a common complaint from obstetricians when we perform an epidural is they had a great CTG trace and then the epidural is inserted and now they've got a very variable or unhappy CTG trace. And there can be a few different reasons why this occurs. Sort of the more serious of those reasons is if you've made the patient hypotensive through the epidural, and that hypotension is going to result in decreased perfusion to the uterus and an unhappy baby. It's uncommon with the low dose local anaesthetics that we use because the block is more gradual and it has less sympathetic blockade, but it can still occur. And so how we would aim to avoid it is by doing test dosing, so a small dose at the start in case you've accidentally performed an intrathecal injection and you've not realised, and we'll slowly titrate that up over 10 to 20 minutes using a low concentration local anaesthetic, giving fluids simultaneously, checking for blood pressure, and if it does occur, more fluids and generally a vasopressor medication to offset it, and that should fix the hypotension of the CTG. And the other common cause, which is a little bit of when your epidural works too well and why it can make the CTG go off, is that when someone's in labour and they have a lot of pain, they have a lot of adrenaline being released, and that adrenaline does a number of things, but it's also a smooth muscle relaxant, and so that smooth muscle relaxant works on the uterus, and so it helps to relax the uterus. If you then perform an epidural that completely removes their pain, they have less of that circulating adrenaline, and that adrenaline was previously relaxing the uterus, and then you take it away, and you potentially can get a hypertonic uterus in response, and it's squeezing down on the baby and making the baby unhappy. And that is generally can be treated if it occurs with a beta-2 adrenergic drug like terbutaline or salbutamol. And then in terms of the baricity, so the positioning for spinals, we will generally have them left lateral tilt to offset the uterus from the inferior vena cava and the aorta. We use heavy bupivacaine, so heavy is just, it's the same 0.5% bupivacaine, but they've added sugar to the mixture, and that increases the baricity. What that means is in CSF, that local anaesthetic is going to sink. And so if you look at the bottom picture, that's it sinking in the back, and it sinks around the curvatures. And so if we wanted to increase the block height, we'd put the patient head down, and that local anaesthetic would sink towards the head, or if we'd made the block too high, we'd put the head up, and that local anaesthetic would start to sink back down and hopefully reduce the block height. Then a feared complication of any neuraxial procedure, whether it's an epidural or a spinal, is an epidural hematoma. And this is where generally in the lumbar space you have bleeding that gets out of control and it becomes physically quite large, and that compresses the spinal cord, and it potentially can cause paralysis, which is a devastating complication. But fortunately, with appropriate screening of patients, it's exceedingly rare. And so audit data out of the UK is showing that it can be anywhere from 1 in 150,000 to 1 in 220,000 if you don't do it on those patients at a high risk. And it could present as progressive numbness and weakness, incontinence and back pain. Where we would generally request platelets prior to performing an epidural is to look for this, and most places would say if you had well-functioning platelets, a level greater than 80 would probably be safe to do this procedure. But if the platelets aren't well-functioning, such as preeclampsia or HITS, you'd be less likely to perform it. And if it was preeclampsia, you could have had a platelet level done previously, but it has dropped in that time. So if you had preeclampsia, you'd want to do a platelet level immediately prior to performing a spinal or an epidural to check to see it had not dropped. And then the other complication, there's many complications, but the other common one is a post-dural puncture headache. And in terms of epidurals, it's roughly about 1 in 50 to 1 in 100. And with spinal anaesthetics, because we use a very small needle, it's generally in the range of about 1 in 500 to 1 in 1,000. How it can present is it can present as either a mild or very severe headache, which is postural in nature. So if they're lying flat, the headache should disappear. And if they're sitting or standing, the headache should become severe. And this is because you've made a hole in the dura. And so as they stand up, gravity causes the CSF to come out of the back. And then there's less CSF in the body and the brain. And their brain starts to sag. And it can pull on the meninges and cause a severe headache. It can cause some other symptoms like photophobia and cranial nerve problems. If it was non-postural, so it didn't change based on position, you would generally consider an alternative diagnosis. And they usually present within 1 to 2 days after your post-dural puncture headache. And they generally resolve within 7 to 10 days without intervention. But the next slide, I'll talk about what you can do if it does occur. So bed rests or lying flat should alleviate the symptoms, but a patient who's just had a baby, you don't want them to lie flat for up to a week because they're at risk of DVTs. They also need to get mobilising and care for their baby. And so what we'd start off with is simple pain relief to begin with. So paracetamol, an anti-inflammatory like diclofenac or ibuprofen. There is some weak efficacy over caffeine and fluid that might help a bit with the headache. And they would also consider, if needed, some strong pain relief medications such as oxycodone or tramadol, even though it won't get rid of the headache, just to help get them moving and wait for that 7 to 10 days to pass, but by the time the headache should have resolved by itself. But the other alternative is to try to fix the headache, is an epidural blood patch. And this is quite a strange or a unique procedure where you've made a hole in the dura, and what you're trying to do is perform another epidural and inject down some of the patient's own blood down that epidural to clot over the hole and seal off that hole. And it does two things. The blood that you inject makes a small mass that compresses the dural sac and helps to increase the pressure that way, and it hopefully clots over that hole and seals off that hole, so you have less CSF coming out and the headache should resolve. But it doesn't always work, and it does have some issues such as back pain, and also you have performed another epidural, so you could potentially make the headache worse if you hit the dura again. And then caesarean sections our real roles of the anaesthetist are to provide safe operating conditions to allow the baby to be delivered while looking after the mother and preventing her from harm. And our two options for this are either a regional technique, or such as an epidural or a spinal, or a general anaesthetic technique. And we generally always prefer to do regional where possible because it's safer than general anaesthetics. There's less risk, there's minimal to no risk of aspiration, and obstetric patients are more likely to have difficult airways. It makes the mother and the father happy to be there while their baby is born and remembering it. There's less drugs that go to the baby, so the baby's generally more awake when they're born. And because you've done a spinal and usually you insert intrathecal morphine, you get better pain relief afterwards compared to a caesarean. But the downsides are you have an awake patient, which can sometimes be difficult if the patient's not tolerating it well. A spinal will basically always result in significant hypotension, so you need to have some way of offset that, usually fluids and a vasopressor medication. It can take time to insert a spinal, so if it's a category 1 where you're trying to rush to theatre very quickly, you might be more likely to perform a general anaesthetic because you know you can have them asleep within 1 to 2 minutes, but a spinal might take 1 to 2 minutes, but it might take 10 or 20 depending on how easy or difficult it is to do. So that's where the delay can be an issue. And sometimes it doesn't cover everything completely, at which point you might get pain during the caesarean, and that talk will be covered a little bit later. And then general anaesthetics, why we would do it is, say, if the mother requests it, so she did not want to have a spinal or be awake during the birth. As mentioned, if there's urgent surgery, if there's a reason we couldn't do the spinal, so in particular if they are coagulopathic, or if we had tried and were unable to do a spinal or an epidural. But the issue is whether it's a more risky procedure, principally because the airway is more likely to be a problem and they're at higher aspiration risk. Obstetric patients have a higher rate of awareness compared to non-obstetric patients. The main theory behind that is we underdose the medications they go off to sleep with because we want to give less to the baby so the baby wakes up more awake. That's something to consider. And they're also at more risk of PPH compared to a spinal because the volatile gases we use can relax the uterus when it should be contracting after the baby's born. Then the technique, I won't go into too much detail, but you want to assess the patient fully and in particular pay attention to their airway assessment. I've mentioned the left lateral tilt like described before. Pre-oxygenate them well because you know they're going to desaturate quickly and also their airway is more likely to be difficult. A rapid sequence induction because they're at higher aspiration risk. And you'll generally have a less than normal dose of opioid prior to the baby being born, so the less drugs go to the baby. And then once they're asleep, how you maintain them, everyone's a bit different in terms of what they use, but you can use the volatile gases or you can use propofol. The TIVA stands for total intravenous anesthesia, so continuous propofol infusion. The volatiles can relax the uterus because they're smooth muscle relaxants, and so this can potentially affect the contraction that you want after the baby's being born. That can often be offset by supplementing your anaesthetic with some nitrous oxide, which does not have the same effect. The propofol infusion should not affect the uterus at all, so it's quite beneficial from that side of things, but it is quite cumbersome to get set up quickly. There is interpatient variability and a higher risk of awareness with propofol, which just needs to be considered. And because they've not had a spinal anaesthetic and you've not performed the intrathecal morphine, we'll generally perform an abdominal wall nerve block as an additional pain relief technique. Extubate them awake because they're at an aspiration risk and they might need more pain relief than a standard caesarean section, so you might consider a PCA afterwards. And then a bit around the sort of drugs we give. So we have access to carbetocin, which is very similar to oxytocin in its mechanism of action, but it binds irreversibly to the oxytocin receptors. So it works at very quick onset and it lasts for hours. There's no need to top up and it's a single dose, but it is limited by, I think it's more expensive than oxytocin. Oxytocin is the much more commonly available one that's been around for a long period of time. It works quickly. We'll generally give slow titrated doses of a few units at a time because large doses can potentially drop the blood pressure, but they might need an infusion for afterwards because the oxytocin can wear off. And then the second line one, ergometrine, which is every anaesthetist's enemy because it's absolutely guaranteed to make the patient throw up. We would only give it if there was issues with tone after the oxytocin or the carbetocin, and how we generally give it. So it's either intramuscular or IV, but the main thing to be, if you're giving it intravenously, is to just give it very slowly because it can cause very significant hypertension quickly. And we'll often give an antiemetic first and warn the mum that this might make them vomit pretty soon. And then the last slide is just talking a very quick bit around pain relief afterwards. So what you want after they've had a caesarean is you want to get them moving as quickly as you can. So you can get them home, you can get them caring for their baby. And what we would do routinely is a standard patient would get regular paracetamol 4 times a day. they'd get a regular anti-inflammatory, whether that's ibuprofen or diclofenac or celecoxib. And those two together, regularly, sort of 3 to 4 times a day, are very effective at getting their pain under control. And then they'll often have, if it's a spinal, some of that intrathecal morphine on board, and then they have PRN access to an opioid medication, usually oxycodone or tramadol or morphine, depending on the hospital that you're at. And that is a very quick snapshot of obstetric anaesthesia. Any questions?
Mungkin setelah presentasi kedua dan ketiga baru kita masuk ini.
Oh, is that?
Okay. Okay. Thank you,
Yes.
Thank you, Dr. David. And now, Dr. Anuraju, I invite you to start the lecture.
Sorry about that. Just some IT issues. Just be back with you in a second. Ingin maaf untuk IT issues and bahasa Indonesia saya tidak kurang baik untuk konversasi yang formal. Atau oleh karena itu saya melanjutkan presentasi saya di dalam bahasa Inggris. Alright, so how good was last night? Fantastic, isn't it? So I guess all of the BICCM team unanimously agree that the Anesthesia band was the best band, right? So congratulations. All right, so and thanks for the run that we had the other morning. So today we're going to have a little bit of history of what is obstetric anesthesia. I want to talk about what is neuraxial anesthesia. After the history, I'll talk about what is new in neuraxial anesthesia, mainly with regards to history, examination, investigation, consent, just like how we do the PL conduct, modalities, equipment, maintenance, and what's new in non-neuraxial analgesia, and what's new in non-pharmacological methods. Just briefly touch through that. So before we do that, just go back in time for history and ask you a question on who's this? Any idea who this gentleman is? You must know his name from, he's not an anesthetist, you might know his name from the forceps, isn't it? So what's the forceps called? What's this forceps? So any idea? Any takers? You know his names from his. So this is a Scottish obstetrician, it's called James Young Simpson, and he is credited to be the first person to give obstetric analgesia in patients. So the Morton first described the use of ether in 1846, October 16th, and 3 months later he provided the first ether analgesia to a lady in the UK. So he came to the UK shows and gave analgesia. So first in ether, and then he switched to chloroform. So for switching from ether to chloroform, he has to experiment on himself, and this is how he was found in the evenings in his lunch, in his dining room with his friends, for experiment on chloroform. So imagine doing that these days, you'll be debarred by medical board, won't you? Anyway, he didn't die, he didn't overdose. He lived to live his tale, and so do you know the first obstetric gadget, what they used initially for giving obstetric analgesia? It's nothing but a single handkerchief, all right? So this is Samputangan, that's what they used to give obstetric analgesia. So he had a problem. It wasn't recognized, and he had a strong opposition from church and his peers. It was considered unethical to give analgesia for labor those days. So they ended up having, so who can trump the church? So the only person who can trump the church at the time was the Queen. All right, the Queen was having her 8th and her 9th baby. She had fed up with the analgesia at that time and said, I need pain relief, all right? And then she decided, John Snow was her private obstetrician, and he gave her analgesia by using. He's quite a pioneer in chloroform and other in the anesthesia field, and he used again handkerchief for the Queen, and again he sort of came over and then developed more instruments to deliver chloroform more accurately. Nitrous oxide again was considered as a party drug. Humphrey Davy was having a party, people were running around, jumping around the furnitures and laughing. So he decided, I might use this for my medical practice, and nitrous oxide came to play. Oscar Kreyes, a German, was the first person to give analgesia for labor using cocaine, using spinal. And Walter Stockel gave cordon analgesia using cocaine, so that's when you're encroaching into the epidural space. And Cleland dissected the pain pathway in dogs and came up with and sort of proposed continuous peridural caudal analgesia. So up until then time, they used to use continuous spinal. You can see the patient, and using metal needles which are malleable. So they had, like, gaps in the bed to accommodate for that needle jutting out of the back. So then that's when our own Tui decided, all right, I'll invent a needle, and he used ureteric catheter to do continuous spinal. So that's why he invented needle. Tui invented a needle for a continuous spinal anesthesia, not for epidural anesthesia, all right? So, and so he was doing ureteric catheter through the Tui needle to give continuous spinal anesthesia. And then Dogliotti came around and he developed the loss of resistance technique, and this guy, Pio Manuel Martinez Coelho, was a Cuban who worked under both of these guys, Tui and Dogliotti. He's the one who married both things and came with continuous epidural with a Tui needle with a ureteric catheter, right? And then now we have the epidural catheter that it's all been refined. So when you do an epidural, take a history, examination, investigation, and do the epidural, and finally you have a maintenance. So that'll sort of complete the picture, and that's how I'm going to break this talk onto. So coming on to history, examination, investigation, this is the epidural space as Dave's talked about. You can see lots of stuff in the epidural space. All this yellow thing is the epidural space. You can see the fat, the lymphatics, the blood vessels, and all those things. It's a potential space, but there are lots of rubbish in that space. So unless and until the local anesthetic goes through all these things, it's quite hard to this. So all the epidurals are not going to work. So when I talk to a patient, about 10% of the epidurals may not work, and that's what they say in the literature these days, in a retrospective study. About 12% it may not work, 50% may need replacements, and some of them need multiple replacements, and most of them report good pain relief in labor. Nowadays, from an examination perspective, what's new is the new number is 70,000 for platelets. So there'll be lots of QR codes in this. Like, if you have scanned the QR code, they'll take you direct to the articles. All right. So if you want to, you can scan those QR codes. But 70,000 is just a number. A patient might more than a number. Look at the trends. All right, so the number, so trend is more important. So the patient might have gestational thrombocytopenia with the blood platelets of 70 and 72 and 73. You might do an epidural on them, but another patient would have a preeclampsia, having a platelet of 110 in the morning and like 150 in the morning, in the afternoon it's 74. You may not do an epidural on them. So trend is more important than the number. So, in 2020, all of us were locked down with COVID. People were all over the world were locked down. People didn't have anything to do. So some of the doctors tried to do some large retrospective studies, and they came up with a bombshell article which rocked the anesthetic fraternity, saying that in JAMA, they looked at a retrospective cohort study and saying that there is a high incidence of autism in people having an epidural. So that is about, you can imagine telling patients, so you can have an epidural, there's 1 in 3 chance that your child will be having autism spectrum disorders. That's not a good thing, isn't it? So, people, everyone went up in arms. There were other people who did counter studies, and now that's been disproved. And the final nail in the coffin came in an editorial last year in the British Journal of Anesthesia, which sort of put the nail in the coffin, saying epidural anesthesia is safe, doesn't cause autism. One of the proposed mechanism was fever. It's a sort of an immune-mediated mechanism, even though it's not clear. But there are lots of studies to show that it's a fact that the patient can be febrile with epidurals, but there is no evidence of autism with fever. Do epidurals increase the risk of operative deliveries? When we started doing epidurals, when they used to use high concentration of local anesthetics. Nowadays, it's been moved on to lower concentration of local anesthetic, and we don't have much of an incidence. There's no evidence to show no incidence and risk. So we have the neuraxial anesthesia these days, which Dave has mentioned about spinal, epidural, and all those things. I won't be covering those things. Epidural, slow to act. Spinal very quick to act, but we can't put we can't have continuous maintenance, and you get a best of both worlds by combining spinal and epidural CSE. As Dave's mentioned, there is an imbalance between oxytocin and adrenaline in CSE, so you get about 5 to 17% fetal bradycardia with CSEs, which can be resolved by simple measures, as Dave is normally mentioned to you. Right? So nowadays to marry, so because of the fetal bradycardia, people came up with another concept called dural puncture epidural. Right? Dural puncture epidural is nothing but a CSE. So CSE, you put a needle through this, so you needle through the subcutaneous epidural and then put a smaller needle to a CSE and put some medication in. But dural puncture epidural, they do just put a epidural in and then put a spine needle in, create a hole, and no medication is injected and come out. Right? So that's what they do. That's what DPE is. The logic behind that is, this is an old study in 1994 through monkey meninges. So if you use a 24 gauge and above, there can be local anesthetic going from the epidural space into the spinal space, and that can give a bit more pain relief. So it's sort of a middle ground between a CSE and a DPE, and a CSE and an epidural. So it's not as quick as epidural. So what does the evidence say now? So this is an article which is hot off the press. It came up last week in the British Journal of Anesthesia. It's a meta-analysis which shows comparing epidural versus DPE, looking at about 214 patients. It says the DPE is faster than conventional epidural. And also there are some other summary of this, which is on this end, which I will blow up so that it becomes it's too crowded there, so I'll blow that up and show you that DPE causes quick onset of analgesia, unilateral block, sacral sparing, motor block is less likely, and the analgesic quality is better with the DPE. So coming on to how does CSE compare with DPE? Another article that came up early this year. It's a randomized control trial, continuous CSE versus dual puncture epidural. The result of that is there was no significant difference in the quality of labor analgesia, but the pain scores is 15 minutes is significantly lower in CSE anesthesia. So this prompted an editorial, which sort of echoes my call on what on this sort of issue where if you're creating a hole in the epidural space, you may as well put something in this. All right, so that's what my take on it was, and that sort of echoes in this editorial saying, should adopt a patient-centric approach to embrace the combined spinal epidural these days than just the CSE or DPE. So coming on to, so you did the maintenance, now doing a spinal, doing an epidural. So if you have an epidural patient like this, it can be quite difficult to do a spinal epidural, isn't it? So that's when the ultrasound comes in. So ultrasound is getting much more popular with these patients. So you can put you do two views. One is a paramedian longitudinal view. You can see this. You can so we'll see the sacrum, the epidural space, lamina, epidural space, lamina, epidural space. All right. So that's what you're seeing here, right? Sacrum, epidural space, sacrum, ligamentum flavum, sacrum, laminar, ligamentum flavum, lamina. So that's what you'd see. And in artist impression, it looks like Gigi Gargaji. All right, so that's what they see. That. So you can see the Gigi Gargaji here, isn't it? You can see that. That's what you see in a paramedian view. And then you turn medially, and you can see when you're on the spine, you can get a shadow of the spinous process. And then you see, if you go in between the space, you get the articular processes, the transverse processes, the ligamentum flavum, and all those things. So in artist impression, it looks like a war terbang. You can see the bat here, isn't it? So you can see, so that's the same thing that you're seeing there. So in actual fact, and then you get a point and you should just mark that X marks the spot and do the epidural for you. But in actual fact, this is what you'd get like, nothing is marked for you. So Alexia from Singapore has come up with a clever instrument called an AI in ultrasound for spine, where he's loaded up lots of things and got an algorithm, and then you span the picture and it marks things for you. But they have a problem in Singapore. They can't get this validated in patients with BMI of less than 30. They don't have many patients more than 30. So Laura is doing a study. She's going to validate that study in Adelaide. From next week onwards, I think we are going to start. We got approval for it, and we're going to do a study to validate that for more than BMI of more than 30 in these patients. So that's what we're going to do. So there are some epidural needles that's not in the market. It's been trialed. This is for epidural pressure measurement. You need just to find the loss of resistance, get a bit more validity. You get connected to a manometer, and then you might get epidural pressure measurement. This goes through an optical approach. It's called a sensor at the end, which shows some clever clever lights and stuff going through it, and then it analyzes force in different layers. Sorry, that's what it does. This uses an endoscopic scanner and tells us when we are in the epidural space. All these are not commercial. It's all in the pipeline, right? It's all been measured. So coming on to history, examination, investigation of the thing, and then you need to maintain it. The gold standard of labor analgesia these days is due to dilute local anesthetic, as Davis mentioned, with manual intermittent top-up. So you top the patient up. The patient can use a PCEA nowadays with background epidural infusion, which can be either intermittent, where you get intermittently, you get 10 mils, 10 mils, 10 mils, or 5 mils, 5 mils, 5 mils, or it can be continuous, like 5 mils per hour or whatever. But 5 mils per hour is totally different to 5 mils every hour, all right? So continuous infusion is out of picture because it gives more motor block. And so if you can imagine, you can see, if you're putting an epidural catheter in, you're putting in 5 mils per hour means say you get a drop and a drop and a drop and a drop. All right, so that's what happens when you program the pump as 5 mils per hour. So what happens there? So you get a drop and a drop and a drop and a drop. It sort of solves a small pool around one part of the epidural space. But rather than if you give 5 mils every hour, you push 5 mils every hour, or 10 mils every hour, what happens is the force would just push the local anesthetic around the spinal cord and gives a better block. All right, so that's why 5 mils per hour is totally different. So that's called PIEB, or programmed intermittent epidural boluses. Every hour you get more and more local anesthetic pushed in, so that sort of plows in through the space and gives better analgesia. So it also creates a bit of, and every hour you drop in, there is always a gradient. If you give a continuous infusion, there's always a gradient around the nerves that gives a strong motor block if you give a continuous infusion. But if you give it every hour, the local anesthetic washes off, and there is not much of a motor block there. So nowadays we use 0.1% ropivacaine with 2 mics per ml of fentanyl because it's by itself it causes good pain relief, not much pain relief, but if you combine both, it gives very good pain relief. That's called a synergistic effect. So that's the gold standard which we discussed. So what in our institution we use 10 mils every 20 minutes, that's the PCEA bolus, and then you give 5 mils every hour, all right? That's the PIEB, or programmed intermittent epidural bolus. And we give the midwives another option to give another 10 mils every hour. So that's what we prescribe. So nowadays there are, Dr. Sia who's here last year for ISOMAC, he's got computer integrated PCA. He looks at the patient's usage and he's got an algorithm which increases or decreases the amount of local anesthetic you have to give. Remifentanil is catching up. It's highly potent local anesthetic. It can cause delayed respiratory depression. So it can have a trend to lower the boluses, all right? Just take another 1 minute, huh? And there are new boluses. So remifentanil, there's an audit that came out of Manchester. It's routinely used with 92% satisfaction rate. So it's all catching up these days. And Professor Sia has got new vital signs integrated PCEA with an algorithm which measures the patient's blood pressure, heart rate, and the respiratory rate, and comes up with an algorithm. All right. Sterile water injection is something that comes up quite often. It's quite so cheap to use. It's just effects like Tiger Balm, where you have when you have it, it's quite it burns. And after that, like when you have a headache, you apply Tiger Balm, it burns, and then the pain just sort of settles off quite quickly. The pain's still there, but it's not as bad. The same effect when you put that, this is the first stage labor pain distribution. You put it in, and then it burns it, and then the pain sort of lingers on. And then there was a randomized controlled trial, international, which our institution was a part of. So sterile water was a placebo. That's about 30 to 50% reduction in pain. The sterile water group lasted to up to about around 90 minutes. So that's just pretty good. All right, so that's about it. Summarizing, neuraxial anesthesia gives the best quality of pain relief. Dural puncture epidural is novel concept for improving efficacy, but CSE is quicker onset of analgesia and DP is no compromise in quality. Dilute local anesthesia with opioids are the way to go these days, and PCA and PIEB are the gold standard. And smart epidural needles are coming up. Computer integrated PCA are showing promises. And remifentanil PCA can deliver less invasive analgesia, even though it's not as good as pain relief labor. That's about it. Terima kasih banyak.
Oke. Terima kasih Dr. Anuraju.
Always a pleasure and such a warm reception every time. So thank you very much again. And I just want to echo Anu's sentiments that Anesthesia has the best band in the hospital. So well done. I'm going to talk about something a bit more specific. Thank you. Something that's very close to an interest of mine, close to my heart, and something that we've all seen before, and I thought was a quite useful method. Oh, easy. Thanks, man. See if this works. Hey, what we're going to talk about today is spinal-induced hypotension. The anaesthetists in the room, who has seen this before? No one? Am I doing it wrong? Oh, maybe I am. We'll talk about sort of why it happens. I think there was a bit of a change of how we thought about the mechanisms of spinal hypotension a few years ago. We'll cover that. We'll talk about how we manage it and how best to manage it, I think, with some guidance on that. And then some novel approaches and some things that maybe you can do here to help assist with this pretty universal problem. There we go. All right. Despite maybe not all of you in the room having seen this, I see this all the time. When you've got a healthy patient having a cesarean, an elective or non-immediately urgent cesarean section with a spinal anaesthetic, hypotension is essentially par for the course. Everybody gets this. And while most of us, I think, would treat spinal hypotension for maternal well-being, no one likes having a vomiting patient in front of you. It's actually significantly important for the fetus as well, because it does potentially threaten fetal well-being at a time that is very difficult to monitor the fetal heart. At our institution, the midwives will do a fetal heart rate immediately after we have completed our spinal anaesthetic, often before that spinal anaesthetic is working. And if we compromise uterine blood flow to the fetus, that can have some negative outcomes on the fetus potentially. There's, I think, modern compelling evidence for that fact is actually lacking, probably because we do quite a good job most of the time anyway. And it's probably that a longer duration of hypotension is worse than extent of hypotension. But as I said before, it's deeply unpleasant to have a patient having a cesarean, profusely vomiting before their spinal anaesthetic. And for those of us who are trying to look good, it doesn't look particularly good. So why does it happen? So when I started anaesthesia training, I think there were quite a few different ways of managing this, which I think reflected our potential lack of understanding. Over just in the few years before I started training, there were some real advances in our understanding of this. And mostly an establishment of our understanding that it was really caused by a loss of sympathetic tone, reducing vasomotor tone and vaso more than venodilation, but both occur. And if you remember from where we studied this in our junior anaesthesia years for our primary exam, if you drop your resistance for a fixed cardiac output, you will reduce your blood pressure. And that manifests in many ways, as I mentioned before. There's a pooling of blood does occur in the lower limbs, venous capacitance vessels, mostly. However, that's usually not a primary issue because cardiac output is generally maintained. And what happened in the sort of late 2000s, early 2010s was some interesting studies using cardiac output monitoring, so LIDCO, transesophageal Doppler, which showed that the cardiac output tends to increase in the same direction as the heart rate. So as you see a spinal start to work, the heart rate increases, and that reflects an increase in cardiac output, trying to, through baroreceptor reflexes and the sympathetic nervous system, to maintain mean arterial pressure. And that was, I think, a bit, there was a bit of debate in the literature about what the exact mechanisms were, and these more advanced monitoring techniques actually showed that this was the case. And this happened just before I started anaesthesia training. And it took a while. Like all things, changing practice does take a while. I had when I started as a junior registrar, the way that my supervising consultants would treat hypotension was massively variable. And then eventually it settled into the way that we do things now in Australia across the board, and hopefully here too. our patients are particularly prone to this. They have, mostly because of the way that our spinals work. We, of all the modalities and the ways that we test for and the types of blockade that we see, the sympathetic block is actually the highest from a point of insertion, higher than pain and higher than soft touch sensation as well. And our use of hyperbaric bupivacaine, like Dr. Barlow talked about before, and also for the need to achieve quite a high level of pain relief during a cesarean section with an awake patient means we need a fairly large proportion of our sympathetic tone removed. The physiological changes of pregnancy can both increase and mitigate these effects, however, overall drastically increase the effect of our spinals on hypotension. Despite an increased plasma volume, which we all probably are aware of, patients have a lower baseline BP when they're pregnant anyway, and you absolutely cannot overstate the importance of aortic caval compression and the reduction and mitigation of that. So, what do we do about it, and why I'm talking about this today? And there's a lot of ways to manage this, which I'll describe shortly. And classically, and I think I would love to hear, by the way, at lunchtime what you guys do here. I'm going to talk about what we do. I'd love to hear how you guys manage this as well, if it's different or if it's the same. But classically, aggressive fluid loading and vasopressor administration. Usually, when I started, it was bolus administration. With the caveat that patients who are high risk for cardiac disease, for example, or patients who had to have more aggressive maintenance of their MAP needed potentially more aggressive, more invasive monitoring or treatment as well. But ideally, the management should fix the problem that we induce, which is primarily, as I said before, vasodilation. Alpha-1 agonists are the drugs that we have that we can only really use at this point, and I don't think that will change. And ideally, if you can avoid this happening in the first place and maintaining both maternal and neonatal perfusion, at least until delivery, is ideal. As we'll see shortly, what we do is a real multimodal type of approach, and I'm sure you guys do as well. It hasn't been studied, and it's because generally when you look at the science, and I have in some detail, you tend to not compare packages of interventions. You tend to compare two interventions together. And I'm always aware coming here that what we do isn't always applicable to Indonesia or to Bali, and that there's often either availability or cost barriers to achieving ideal management, which is why I'd love to hear how you guys manage this later on. That's me there, and I was involved with several of my colleagues, mostly Alan Sinner, who has done multiple Cochrane reviews in his extensive, exhaustive career in research, and I looked at probably over 100 papers for this Cochrane review, which I wouldn't recommend reading. It's 400 pages long, and it's very, very boring. But it is a really broad review of the evidence that was out there, at least pre-2020, for prophylaxis, so prevention of hypotension after spinal anesthesia. I started this as a registrar. I was taken over by two of my colleagues, Cheryl and Julia, Cheryl really did the heavy lifting on this and got it published in 2020. And it looks at multiple interventions, both sort of physical interventions and pharmacological. Don't go and read this paper, even though I've got my name on it. I wouldn't recommend you read it. It took years off my life, this paper. The problem is that you're comparing so many different types of interventions, often ones that have been shown to be not particularly valid anyway, and there was a huge amount of bad science out there, and that's what Cochrane reviews, I think, try to solve as a very large meta-analysis type of project. However, comparing two disparate types of treatments is not particularly fair. But looking at places where they're doing obstetric anesthesia, you've got pretty confined populations who are easy to study, easily to grab 100 patients and compare two interventions. But there's a lot of bad science. However, more recently, it's just before this came out, we got an international consensus statement, which is multiple highly respected, esteemed obstetric anesthesiologists from primarily the Western world, looking at a comprehensive and really evidence-based review, and the best quality evidence, but wrapped up in an opinion sort of piece, really. It's a consensus statement and opinion rather than, but it's very well referenced. It does specifically, and this is a paper I would recommend that if you were interested in to read, it does specifically address areas where you've got resource limitation and alternatives to the ideal scenarios that they discuss in this paper. And essentially, you can't really beat the use of a vasopressor infusion, which has started very early during in the cesarean, ideally an alpha-1 agonist, which is the most optimal way to treat this. So, what do? We don't just use this, we use several methods, and as I said before, combining multiple things, and which has really happened over 20 to 30 years, really. Putting multiple techniques, decisions together to reduce this means that we now rarely see problematic hypotension for an elective caesarean section in a healthy patient, which are the vast majority of our patients at the Women's and Children's Hospital. And it's a combination of both physical and pharmacological approaches, the pharmacological being the most efficacious. However, things like TED stockings, which all of our patients get in Adelaide, in the Women's and Children's Hospital, which has obviously a compressive kind of reduction in venous pooling effect. But all of our patients get a pretty big IV. Over my career, we've stopped putting in 16s for everybody. Most people get an 18 now, which is fine until you have a hemorrhage and wish you'd put in a 16. We also do. Most people would do some kind of IV pre or co-load or kind of a combination. There's subtle variation in how we do that, but all patients get at least a litre of crystalloid unless they're ragingly preeclamptic. And as soon as the spinal anaesthetic is complete, we start a vasopressor infusion I'll talk about that briefly in the next slide. We also do other things, and I'd like to again, like to hear how you guys do it, and I'm sure you probably do something similar here. But over time, we've really decreased our dose of hyperbaric bupivacaine that we put in our spinals, which does definitely reduce or mitigate at least the severity of the hypotension that we see after a spinal anaesthetic. And again, strict left tilt positioning once the patient is supine absolutely can't be understated at any point. So this is what it looks like. We use metaraminol, which is a very old drug, which is very poorly studied, but we know how to use it very, very well. We use a 10 milligram, that's 10 milligram ampules, which we put into a 20 mil saline solution and then run on a pump, as an infusion pump. Again, there's a bit of variability to how people exactly run that. There's a bit of variability at starting point, whether you give a little bolus to increase the blood pressure or try to get ahead of the blood pressure drop, which we generally titrate just to blood pressure and potentially heart rate. One of the consistent themes in the evidence and literature about this is bradycardia being a problematic, particularly using phenylephrine, which is what the international consensus statement recommends as a pure alpha-1 agonist, a direct-acting alpha-1 agonist. However, in Australia, we have a significant experience using metaraminol. It's far softer, it's less potent, has a lot more kind of probably better therapeutic index, and you don't see as much bradycardia as you do, or certainly in my experience, with phenylephrine. And there's a big concern about bradycardia essentially meaning a reduction in cardiac output and forward flow. I take that on board. However, I don't think the bradycardia we see in caesarean sections, certainly if we're keeping MAP high, as problematic. And what we do is we start that as the spinal goes in, and generally in someone who's not experiencing significant blood loss and who's otherwise healthy, we often don't need that after the baby's delivered. we've switched to using carbetocin for the vast majority of our cesarean sections, and despite the evidence not supporting that, anecdotally, carbetocin is far softer on the blood pressure than its predecessor, oxytocin. So often, unless there's bleeding or there are other reasons for the patient to be hypotensive, we start to come off the vasopressor soon after delivery. Some people still use bolus vasopressors because maybe they're not as lazy as we are. It's far more hard work and need to pay far more attention. Phenylephrine, people still use in Australia. It's popular, I think probably worldwide. It's far more used than metaraminol, which is unique to Australia and the UK, as it seems. And some people still use ephedrine, which is a pretty good option. It's slightly different pharmacology. And people often, well, if they're using it, well, potentially not often, I should say, but we'll give it non-intravenously to sort of change its bioavailability and its onset to reduce the need to give multiple boluses. A colleague of ours in the northern suburbs of Adelaide gives a 30 milligram IM bolus once the spine was in, and he seems to make that work very well for him. So, and again, at lunchtime, I'd love to hear how you guys do offset your spinal hypotension as well. I think it's one of the most useful things I think I get out of coming here is talking to you guys and seeing how you do things differently. I think it's really, really interesting. However, there's some things that are newish, maybe not so new anymore actually, but things that you guys might be able to try yourself. This came in a few years ago, but we give ondansetron pretty much as standard of care. Most of our patients get POME prophylaxis just to offset the effect of the intrathecal opioids we give them. However, there's pretty compelling evidence that if you give ondansetron before that spinal goes in, is you do some strange dark magic to the serotonergic pathways in the spinal cord, and you mitigate this Bezold-Yarich reflex, which tends to mitigate the severity of the hypotension and the bradycardia that you can see with a spinal anaesthetic. This effect is very reproducible, it's dose dependent, and while it doesn't, I don't think you'd ever get to the doses that would be reasonable to give which reduce your need, or eliminate your need for a vasopressor infusion. It's certainly, and I think anecdotally, it certainly reduces the duration that you need the infusion for. Often I'm turning, if I do this, and I don't regularly, but a lot of our registrars, a lot of our residents do this as a sort of a pragmatic kind of thing. You often can turn off your metaraminol infusion before the delivery of the baby. I always get concerned that if you have someone who has a spinal on board and doesn't need metaraminol, I was worried that my spine was not working. So I do like to see that there's a bit of a blood pressure drop. So I don't do a pre-spinal ondansetron often because it makes me feel more comfortable. And often, and as a PONV prophylaxis, the evidence suggests that you give it at the end of the operation. However, it's got a reasonable long duration of action. If you're going to give other antiemetics, you give it at the beginning, you get a kind of a bonus effect as well. It's a cheap alternative, potential sort of extra step you can take to reduce the likelihood you get hypotension in your patients. And there's quite a lot of evidence now, and this is reflected in meta-analyses that sort of show this is quite compelling. 4 milligrams is enough, even 2 is enough, but going up to the higher doses, if you can, gets more bang for your buck. And finally, the last few things I'll talk about. So we, at the Royal Adelaide, which is a large tertiary hospital that myself and Anu currently work at, as well as the Women's and Children's, we do quite significant trauma surgery, major orthopedics, liver surgery, cardiothoracic surgery. We have a small pilot kind of study looking at the use of peripheral noradrenaline, and I was involved in that last year. And there's sort of increasing evidence that, and particularly perioperatively, that short-term perioperative peripheral noradrenaline is an extremely safe and potentially very useful option as a vasopressor choice. In fact, in Australia, it's actually cheaper than metaraminol, but suffers from a very long period of concern that extravasated noradrenaline could cause ischemia and tissue damage if it extravasates, whereas metaraminol is essentially risk-free in that regard. There's an ICU in Perth who essentially uses this for a large proportion of their patients now, and they demonstrated like a 6-figure cost saving across 12 months by switching to peripheral noradrenaline instead of a central line and or using metaraminol. And its pharmacology being slightly different, you do see less of that reflex bradycardia. It's got this beta activity. And if you're worried about the bradycardic effect of your vasopressor, that potentially this is protective in that regard. And the last thing, which kind of speaks to what Anu showed about the Dr. Sia and his fancy AI technology, is that maybe eventually we'll see closed-loop feedback systems that will make us even lazier anaesthetists, in that we have pumps that will directly measure blood pressure and titrate metaraminol or vasopressor of your choice without us having to actually do anything. I think anaesthesia, as anaesthetists, I think certainly where we work, we get lazy with time by outsourcing our work to machines and other things as well. Not very much unlike the ideal anesthesiologist you have on your wall, which I absolutely love. When the first time I came here, I saw this and I thought it was fantastic, because if nothing else, it means, and it shows that no matter where we are in the world, anaesthetists have the exact same frustrations towards their surgical colleagues, towards the theatre environment as well. Thank you very much. Thank you for your time.
Thank you, Dr. Sam. Okay, and now let us start with discussion session, I think for 15 minutes. Oke, untuk teman-teman, jika ada yang mau bertanya, saya persilakan. Mungkin di awal akan ada 2 pertanyaan. Setelah itu kita akan makan siang bersama. Oke, mungkin ada yang mau bertanya, silakan angkat tangan, memperkenalkan diri dan mau bertanya kepada siapa. Silakan.
Any questions for any of the speakers we had this morning?
Ya. Dr. Rendra, kasih mic.
Hopefully.
Good day, sir. My name is Rendra. I would like to ask about the subcut opioid dose that you use for Dr. David, because in this hospital you usually using continuous morphine around 20 to 50 micrograms per kilograms per hour, or fentanyl 0.25 micrograms per kilograms per hour. So I would like to know the dose that you usually use in your hospital using subcut opioid for post-op analgesia. And for Dr. Anuraju, nowadays people are talking about EREX or early recovery after cesarean section. Based on your experience, which one is better for supporting EREX, using opioid intrathecally or peripheral nervous block for achieving EREX? And for Dr. Sam, the management of hypertension with multimodal, did you mean using every modality that we have, like using a little bit of ephedrine or maybe phenylephrine in conjunction with a little bit of crystalloid loading or something else? And please explain about left lateral position after spinal anesthesia, because it is not something we usually do after spinal anesthesia here. Did you tilt the bed or put some pillow in the back of the patient? Thank you very much.
Oke, semua pertanyaan sudah disikat semua, Dr. Rendra ini.
So subcut pain relief in Adelaide is a bit of a unique part in Australia, because there's a lot of research done by a particular person in Adelaide around it. So we have quite variable doses and large doses of opioid subcut medication. We dose it based on age rather than weight. And there is a dose reduction from a younger patient, and it gets lower and lower to the older patient. The most common one that we'd use subcutaneously would be fentanyl, just because that's familiarity, access, and it's what most people are familiar with. And in a 18 to 40-year-old patient would generally be about 100 to 200 micrograms. which can be given up to hourly if needed, but it does require certain conditions such as appropriate monitoring by nursing staff and supports in place. And there's a set of naloxone order that comes when you write up the opioid, and the nurses have to do checks, so usually within half an hour to an hour after giving that medication. So they can be very large doses, and in not the right environments can be quite unsafe. So you have to have those things in place. But that would be, and then reduce that dose as you get older. So like an 85-year-old, you'd give like sort of 40 to 75 mics, sort of 1 to 2 hourly as your PRN dose as needed. The tilt aspect, so it's one of those, it might help, it might not help. It does depend a little bit on the patient. The standard teaching would be for the obstetric patient to have at least a 15-degree tilt. The reality is very few patients do you give that degree of tilt, and it's probably only about sort of 10 to 20% of patients that might need a tilt. And we do that in theatre by we've got beds that the beds themselves can like electronic beds that can tilt to one side, and we just kind of tilt a bit until we can see the uterus shift, but not so much because you obviously don't want them falling off the bed.
No, don't listen to him. He's teaching you bad habits because he works in the private sector. But it's the same reason that we talked about. For those of you who saw the Code Blue demonstration this morning, left lateral tilt is just to offset aortic caval compression, which is absolutely mandatory in a pregnant patient over 20 weeks. Teaching in all of the emergency responses and just sort of more broadly should always be tilted, should never be lying flat supine, because you can see dramatic, sometimes very dramatic reductions in preload and afterload with aortic caval compression. So in answer to the direct question, we do tilt the bed, just like Dave said. The official numbers are often very subtle, and as long as you've made some attempt to reduce aortic caval compression, whether that's a pillow or whether that's bed tilt, either way is absolutely fine, but you have to do something, because even I've seen patients with significant aortic caval compression despite vasopressor infusions still get quite hypotensive and more problematically symptomatic, nauseous, dizzy, lightheaded from their aortic caval compression. So absolutely, Kim.
Not everyone's the same. And so there are, just occasionally you'll get someone who gets really bad aortic caval compression. So in some of those instances, and what will happen, the Barrett-Jacob reflex, they'll get poor, then they get a braddy. So one of the things you have to do is just get everyone to turn the patient on the side. I've only done it a couple of times, but I've had to do it while you then correct the, get your vasopressor right, get your pulse rate up as well. But it's tricky because the patient's vomiting. And you could just put, you could, if you haven't got enough staff, just push it.
So we do the spinal, start the vaso, you might put this ondansetron in beforehand. Ondansetron, spinal, start the vasopressor, and then when the patient's supine, we tilt the bed and reduce the aortic caval compression.
All right. Thanks for the question. I think very, very relevant questions and important questions. As with Dave's thing, I've just sent Cindy and Dr. Chahia the protocol for, from our hospital with regards to how we use fentanyl, as Davis mentioned. So you'll get a bit more. So all the things that Dave mentioned regarding naloxone and all those things, so the protocol is in there. So if you want to develop a protocol, you can look at that. It's got sterile water as well in it. So yeah, to answer your question, ERAS, what is better, intrathecal opioid or peripheral nerve blockade? The gold standard these days, the cornerstone in ERAS is neuraxyl opioid. All right? If the peripheral block is recommended in ERAS protocols, if you look at SOAP or if you look at European Society of Anesthesiology and all those things, neuraxyl opioid is the gold standard. And peripheral, if you have peripheral nerve blockade, it's not like, if you have neuraxyl blockade, peripheral neuraxyl blockade doesn't help. And peripheral blockade is recommended. It's good if you do it, it's good, but it may not be better than, it doesn't give added benefit if you have neuraxyl opioid. And peripheral neuraxyl opioid is recommended only if you have a GA cesarean section or if you have patient with a high opioid, very high opioid requirement, like an operation with an IV drug use and things like that. So the gold standard these days is what ERAS recommends is a neuraxyl opioid, not a peripheral nerve blockade.
What do you use the intrathecal opioid? Yeah. And what dose? Right. Yep. Yep. Yep.
Fentanyl, because we do both morphine and fentanyl. Fentanyl is lipophilic. So the moment you put fentanyl in, it goes and attaches to that spinal cord straight away. And that gives you a different modality of pain relief, like, for the section. So it's not going to give you long-lasting pain relief, the fentanyl. So that's sort of to improve the quality of analgesia. It goes and attaches to the spinal cord straight away. Neuraxyl opioid sort of lingers in the spinal cord. It's lipophobic, so it sort of stays in the CSF and goes, its action is central action, all right? So you get pain relief centrally. So that's why you put neuraxyl opioid, there is a high chance of patient developing delayed respiratory depression. So that's one of the drawbacks of having neuraxyl morphine if you put a high dose in. So at the institution that we work, at most of the institutions that we work in Adelaide, if it's not for cesarean section, if you do it for hips and knees, they have to go to a high dependency unit. They can't go to a ward because there is a high risk of delayed respiratory depression because it's at centrally. It goes in the CSF and then the CSF get transferred to the brain and it acts centrally there. So that's what's giving you more pain relief. The long-lasting pain relief is done by the neuraxyl opioid, neuraxyl morphine, not the fentanyl.
Yeah, but you don't want to really give more than 100. Yeah. So in Indonesian patients, because like if you're having other surgery planned more, but for these, you'll be going down between 50 to 100.
Not mean to be show off. I'm sorry. Yeah, but
what do you do because that you have to be extremely efficient.
Yes.
I mean, you must start at 6 a.m. and finish at 10 p.m. or something.
In 28, 1530 a day, it handle in 24 hours. I mean.
24 hours. Oh, okay. Okay.
Yeah,
wow. Still pretty busy. Yeah. What do you do? Do you do anything differently to increase your efficiency, either changing your spinal drugs, or do you do different things for blood pressure management?
Yeah, I think it's not big difference because we doing ERAX too. Usually the operator, the obstetrician, doing the session about 13 until not more than 1 hour. Yeah.
That's a dream for us.
Yeah. And I'm usually using heavy bupivacaine, 7.5 micro with lateral
1.5 mils?
Yes.
Yep.
It will with 25 microgram of fentanyl and maybe not more than 100, sometimes only 15 micro, because in my experience, I'm using 100. Lot of patients got severe nausea and itchy. Yeah. In 100, I'm usually only 15 micro, and it's good for them. Yeah. 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 Yes. 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 Yeah. Yeah. I think it's not the big difference because, yeah.
That's a busy day.
Rotom Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenarios. Rotom provides a global assessment of hemostasis by using a saturated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and tomograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the Rotom measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the POCT recommendations. First, take out one level of QC material, Rotrol N or P, and let it reach the room temperature. Dissolve the content of Rotrol P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotrol and scan the Rotrol vial. Open the pouch and insert the cartridge in the device. Insert the Rotrol vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other Rotrol QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenario. Rotor provides a global assessment of hemostasis by using a citrated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on/off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the POCT recommendations. First, take out one level of QC material, rotorol N or P, and let it reach the room temperature. Dissolve the content of rotorol P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotorol and scan the rotorol vial. Open the pouch and insert the cartridge in the device. Insert the rotorol vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenario. Rotor provides a global assessment of hemostasis by using a saturated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and tomograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the BICCM recommendations. First, take out one level of QC material, rotor N or P, and let it reach the room temperature. Dissolve the content of rotor P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotor and scan the rotor vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen. We can print the result at any time. Click on any channel, select Save Clear All to stop the process. Remove and discard cartridge in the yellow bag. To find or to print a patient measurement or QC result, open Database module and select the Patient Measurements database. Add located measurements to the selection box and press Print. Determine the number of thermograms per page. Quit and come back to the measurement module and keep the device ready for the next measurement.
Rotom Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenario. Rotom provides a global assessment of hemostasis by using a titrated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and thermograms. Now let's move to the consumables. The cartridges are stored at room temperature, and Rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the Rotom measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the BICCM recommendations. First, take out one level of QC material, Rotrol N or P, and let it reach the room temperature. Dissolve the content of Rotrol P by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotrol and scan the Rotrol vial. Open the pouch and insert the cartridge in the device. Insert the rotor vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other rotor QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7.
Thank you, Dr. Rodnil. Good afternoon, Prof. and Doctor, and my fellow friend. My name is Yudi. I'm anesthesiology resident here. Thank you for this opportunity, and I'm going to share a case about massive transfusion protocol in placenta accreta. Okay, presenting a woman 38 years with Gravida, second Gravida, para 1, 34 weeks and 1 day, single fetus, transverse, locus minoris resistant, and placenta previa totalis, suspect placenta accreta, and marginal implantation cord insertion with surgery, section cesarean hysterectomy, and backup urology. With anamnesis, the patient arrived conscious, presenting with history of vaginal bleeding since the 3rd month of pregnancy. The bleeding was intermittent, leading to repeat hospitalization. However, pregnancy evaluation consistency show the pregnancy still viable, and currently the patient denies any bleeding since the end of September 2024. She also denies experiencing pain, dizziness, nausea, and vomiting. With surgical history, 2004 appendectomy, 2022 cesarean section, and the patient is a housewife. Prior to pregnancy, she was able to perform moderate heavy physical activity without experiencing shortness of breath or chest pain. With physical examination, weight 63 kilogram, with height 152, and then with blood pressure 120 and heart rate 88 times minute, with FIR 148. With laboratory finding and radiology, blood sample with hemoglobin 10.4 and slight hypokalemi with 3.37, and with USG task, placenta located on the anterior uterine wall extending to cover the internal os, grade impression placenta accreta. With the problems, actual problems with the Gravida hemodynamic, we got microtic hypochromic anemia, post-transfusion of 3 units of pig red cell without sign of active bleeding, which current hemoglobin 10.4, and with potential problem hemodynamic instability, bleeding, postoperative nausea and vomiting. With surgery condition, location abdomen, position supine, duration 3 to 4 hours, with manipulation, bleeding, and this conclusion to ascetry. We prepare the operation with request for 4 unit of PRC, 3 unit crossmat, 10 unit of frozen plasma, and 10 unit of TC. We planning to use regional anesthesia and convert to general anesthesia post-labor with post-operative management with analgesic morphine, and after surgery ICU backup ventilator. Okay, durante operation, hemodynamic fluctuation with blood pressure 62 up to 128 and 42 up to 84 with heart rate 72 to 112 with fluid intake ringer lactate 6,500 and colloid galofosal 1,500 with blood component packet red cell 926 and FPP 388 with fluid output bleeding 9,000 and urine 4,000 milli with anesthesia duration 7 hours 35 minutes and surgery duration 7 hours and 10 minutes. With post-surgery care ICU with ventilator. This is follow-up after the surgery, day 1. The patient with ventilator support, with PCB PEP dengan with fraction 40% and PIP 5, and we check again the blood after the surgery. In the dead 30 with hemoglobin post-operative 8 with hematocrit 23.9 and thrombocyte 91. Okay, this case is about a massive bleeding during obstetric surgery. Is abnormal placenta inversion or AIP or placenta accreta spectrum. It's a condition in which the trophoblastic tissue penetrate the decidua basalis layer and invade the underlying structure, including the uterine myometrium, uterine serous, and may even the surrounding pelvic organ. Massive bleeding during obstetric surgery such as hysterectomy is the #1 cause of maternal mortality and morbidity. This is the picture of normal placenta and the placenta accreta spectrum. The normal is attached to temporal layer in the uterus. That's it at delivery. And at this case, we got placenta accreta when the placenta attached too deeply into the uterine wall. There are several types of placenta accreta. In this case, we got placenta percreta. Placenta growth penetrate through the uterine wall and reach surrounding organ, including the bladder, bowel, ovary, and the other structure around the uterus. The clinical features and diagnostic, the classic symptom of the placenta previa is painless vaginal bleeding during the 2nd and 3rd trimester of pregnancy. The first episode of the bleeding usually stops spontaneously and rarely cause shock and fetal distress. Transvaginal ultrasonography is the gold standard for diagnostic placenta previa. And massive blood transfusion. In this case, we activate the massive blood transfusion with the several criteria, such as replacement of one entire blood volume within 24 hours, transfusion more than 10 units of packed red blood cell in 24 hours, transfusion more than 20 units of packed red cell within 24 hours, transfusion more than 4 units with 1 hour during active bleeding. Replacement of 50% of the total blood volume within 3 hours. This is a resuscitation priority, blood volume replacement, maintaining tissue oxygenation, and hematosis archive. In general, the indication for activating the massive transfusion protocol include any situation of actual blood loss that leads to hemodynamic instability, such as trauma, obstetric hemorrhage, gastrointestinal bleeding, and major surgical procedure. MTP is active by clinical after the transfusion of 4 to 10 units of the PRC or when there is ongoing massive bleeding anticipated. Once active, the protocol guide distribution of blood product in a fixed ratio, such as 1 red blood cell, fresh frozen plasma or platelet, or 2 red blood cell, 1 fresh frozen plasma and platelet, depending on institutional policy, and the main principle to approximate the consumption of whole blood. This is the template of massive transfusion protocol we use in here. The monitoring for the massive transfusion protocol, typically every 5 units of PRC with the parameter like complete blood count, including hemoglobin, platelet count, and coagulation test, PT and APTT, fibrinogen level, measure of concentration, blood chemistry such as PHA, blood gases, electrolyte, glucose, and lactate, and TAG, effluent platelet function and clot formation, like Dr. Cahya before. Clinical and laboratory target during massive transfusion, we have a target like main arterial pressure 60 to 65, hemoglobin 7 to 9, with INR below 1.5, fibrinogen level 1.5 to 2, platelet count more than 50,000, and PHA 7.35 up to 745, and core body temperature more than 35 Celsius. There is a reaction and complication in massive blood transfusion, like allergic, metabolic complication, and other complication. In this patient, we got no complication. Thank you.
Thank you. And now, Dr. Kim, I invite you to start the lecture. I think your time is 20 minutes, sir. Okay.
So I'm going to talk about the fourth T, which is similar to this in major obstetric hemorrhage, because we've got tone, tissue, trauma, and then the last one we talk about is thrombin, which is basically coagulopathy. Have you got my slides? Yeah, right, okay. So, and I'm going to give it from a slightly different perspective about bringing in some other information, which is primarily about correcting fibrinogen. And it plays on to what Anu's talk yesterday about managing fibrinogen being the level, the blood product associated with clotting, which goes down the lowest and which needs to be corrected. So we'll just get the slides up. Yep, okay, so we can quickly flick on to the next one. And I thought, these are the things you need to think about. And one of the important things, I think, is communicating to get, when you have a hemorrhage, needing people to assist in managing it. And also assess what your level of blood is that you've lost. And that's both clinically, assessing the patient's signs. Oops. Oop. Go back. Oh, hold on. And also weighing packs, weighing the blood and guesstimating how much it is. Talk a little bit about, potentially might talk about blood-saving conservation strategies, coordination, continuing monitoring, and post-op care. So that's where the patient may come from that's having a hemorrhage. Maybe elective surgery, or maybe someone who's had a vaginal delivery. And like today, we had someone who had a perimortem caesarean and then would have gone to theatre. And if the underlying cause is, for example, an amniotic fluid embolus, then they'd have ongoing blood loss. So various areas that the patient may come from. And this is a bit about planning and communication, the elective cases. And we've talked about, your case of the placenta accreta that's elective. That planning of those cases where you've got more ability to manage that is going to be really important. What method, getting the family in to donate, or that's really going to be important. And then the emergency cases, all cases, these are the things you might be thinking about. Because with a major, doing a hysterectomy, for example, with a caesarean, they need another, as Chris Sexton said yesterday, you need a second consultant there to do it. And if you're giving blood, there needs to be a designated person who's running between your theatre and the transfusion lab to collect it. So you need to think about that. What are the things that, okay, next one is and the assessment of shock. So the things that we need to be, these are from the National Blood Authority. The thing, estimated blood, what's the response to resuscitation, which the lactate level, the pH, base excess, having an arterial. What I put in the echo is when you've got major hemorrhage, you may, this is what we were suggesting, possibly, you might be putting in echo, some method of testing what the cardiac output is. We've had that slide up yesterday, and that's an important slide. These are the figures of what level of shock it is before you actually start resuscitating. And, which is a pointer? And you can see that really the blood pressure doesn't really start to drop until you've lost till you're in here. But I should have actually changed this slide, the volumes on here, because this is for a Western population. So this is where we've got down the bottom here, beware the patient who weighs less than 50 kilograms, because it's going to be considerably different. Because if you're like a 50 kilogram woman who loses 2.5 litres, they'll be over here, and they'll be, pretty bad. So just think about that. And then they're also, you don't always get, especially if it's an abdominal bleed post-op after a caesarean, you don't always get a tachycardia, because you can have some parasympathetic stimulation that actually blocks the tachycardia. So just rely on predict, and possibly the earliest sign is actually the respiratory rate, and also checking what the simple things like, how responsive the patient is and doing capillary return. So just the next slide. the other thing is if you've got an epidural or spinal on board, and then you have a hemorrhage, there's potentially vasodilatation and sympathetic block related to the spinal. So you need to actually then treat that additionally. So that's a thing to worry about, because that may actually then impact your venous return on your cardiac output. Getting adequate venous access and rapid infusing devices. We've got the Belmont was developed by the US Army, and it can just give the blood, how quickly, it's about a litre in a minute, just like boom. So using those things is really important when you've got a sudden massive hemorrhage. An outline obviously for monitoring and looking at the pulse pressure variation. Blood conservation strategies. I mean, if the hospital gets cell salvage, obviously doing the surgery to actually stop the bleeding, because part of blood management is stopping bleeding. So all those steps, the Bakery balloon, packing, doing a hysterectomy. So we haven't got as many blood products. Moving on to that quickly is important. From managing the coagulopathy, using tranexamic acid as a fibrinolytic agent, 1 gram over 10 minutes. And then if the patient continues to bleed, repeat it again, half an hour later. In that 7-hour case, you might have to repeat again and again. So just because it does get diluted as well. Eutotonics, and avoiding, if you're giving a general anaesthetic and they're bleeding, avoiding volatiles. Change over to some propofol, which David sort of has alluded to. And managing the coagulopathy. So one of the factors, Anu showed you a similar slide yesterday, but the important thing here is to remember that in pregnancy, the fibrinogen level is higher when you're pregnant compared with normal. And that's important because if you're giving people FFP, you're probably giving them, because it's from an adult patient, not a obstetric patient. So you're not actually increasing the fibrinogen. That's the target level, but then when they're bleeding, it drops, and I'll show you that in a subsequent slide. So this is from, I can't remember where I got these figures from, but they're the fibrinogen levels of less than 2, I pulled out 2, of where at these amounts of blood loss, the levels at which in general it'll be low. So we said they've lost 3 litres, probably a quarter of the patients will have a low fibrinogen. Or if you're needing to give them 4 units of blood in 4 hours, about half of them will have a lowish fibrinogen level. This is just a study from now almost 20 years ago in Paris, where they looked at patients who'd had a hemorrhage of more than a litre. Then they looked at the severe group, and their definition of severe was decrease in hemoglobin, transfusion of more than 4 units. They had to do one of these surgical procedures, or the patient died. So that's the severe group. And then if they, this is a bit more detail about the decision to transfuse in the study, and then what they found is that if we compare, this is the non-severe patients who'd had a PPH, and this is the severe group, that it was actually the fibrinogen level being low was significant. So what they then came out from this study was when the fibrinogen is less than 2, then you need to be aware that they're going to be more severe. So and there's a graph of the non-severe and the severe and what the fibrinogen levels were. So it's a warning sign. Now in Wales, they've done a whole lot of work. They did a whole lot of work on postpartum hemorrhage. They got locums in many of the units gradually over a period of time. And this is sort of a study that they did of collecting all the data, and this is, so there was over 10,000 patients over a 2-year period. So we'll just go on to what, so they've subsequently published many papers analysing these cases. And some of it's, and I'll show you just a couple of them. But what they've actually come up with is this idea of like trauma, having an acute obstetric coagulopathy, and then you've got a resuscitative or dilutional related coagulopathy. So that would be more your placenta accretas, where that's more in this field. But if you've got an abruption with a dead baby, for example, that will be, there's hyperfibrinolysis, and it happens here, and it is more fibrinogen related. The other factors aren't as decreased, so you need to be really aggressive, and that's with amniotic fluid embolus as well. So of half of the ones that are defined as acute obstetric coagulopathy, it's AFE and amniotic and AFE and abruption. So this was a study from Wales, and they looked at what the measures were, and they're talking about here the D-dimer was, so the other, do you do D-dimers here? Because D-dimers being high is another factor that warns you of a acute coagulopathy. And you can see here that the A5 and the fibrinogen are the important things. Now, just go on to the other one. So what were the cases that were associated with acute coagulopathy? Was the abruptions, and 5 of the 12 had it, and the placenta accretas not as many. And where is it? If we got AFE, they only had 1 case of that, but they're the things to just sort of think about. So the initial management, where there's a risk, and we're talking about following the rotamalgam. So this is in our hospital, we were suggesting where there's an acute hemorrhage at about 1.5 litres during a rota. But that's in the acute phase. So this is because we've got blood products to be able to manage it. So just going back to the dilutional coagulopathy without massive fibrinolysis, now if you look at the Klaus fibrinogen levels, in here we've got 1 litre, 1 to 2 litres, 2 to 3, and it's only when they get to greater than 3 litres that the fibrinogen, that's a mean, was that range, and the APTT was normal. The platelet count, you hear the platelet count drifting down, and the D-dimer varying. So, and this is a linear with time of the various coagulant factors associated with coagulation. There's also factor 8, which is pro-coagulant, and that actually is a protective mechanism which does actually increase until you get to the 3 litre mark, and then it starts to drop off. So that's it. So So then they also published another paper on looking at patients who've got 2.5 litres or 5 units of blood over a 2-year period. and they found that hyperfibrinogenemia was in 17% and lower platelets in 5%. But in those that had greater than 8 units of blood, hypofibronemia was in 80%, platelets lower than 75 or 35, and an abnormal range of INR and APTT was just 35%. So that's sort of what I'm trying to remind you of is, that's the fibrinogen that you need to be thinking about. And what blood products have fibrinogen? Any questions, any answers? So it's really cryoprecipitate or fibrinogen concentrate. So giving these patients FFP it's okay, but it's not, there are probably better blood products to give them. There's another, I think we'll just flip over. That was how over time with this study, I said that they gradually introduced the use of targeted products associated with Rotem. So if you see here, this is in the first 6 months of the study. They only had Rotem in 45% of the case of the units. So they were using FFP a lot more. Or here. And then as gradually they got up to here, and so they were using less cases of FFP alone. And that's also associated with clinicians then changing their thought processes to using the Rotem-based algorithm to treat. Because if they've always managed a postpartum hemorrhage with the PACS or the one-to-one, they were continuing with that. And also some of those cases, so that's actually quite an interesting slide about change management and the gradual introduction of Rotem. I'll flick over that. Oh, sorry, am I going backwards or? Oh, yeah, so that's, hold on. So this is similar to the algorithm that Anu showed you yesterday, except we've got this one, the fibrinolysis at the bottom. We should actually change it so it's at the top. So understanding and following the Rotem algorithm to actually help guide is really useful. So I've just got a couple of there's the targets. I showed you that case yesterday where the patient had an AFE, and then gradually, and you can see when the patient came in, that was the fibrinogen level. The diadema was 80. So that's actually really, when it's got that, you'll need lots of fibrinogen. And this is later after treatment, and that's after treatment. Yeah, hold on. I'll just go back. Yeah, sorry. Yep. Now, this is a different. I'll just show you quickly. This is a different case, and the patient had actually had a splenic artery aneurysm rupture, and it basically arrested at home, and had been brought in on they had 100 mites of adrenaline when they came in, and we did a perimortem caesarean in ED, and then we took her up to theatre, and that was one of the first Rotems that we had, and you can see there the A5 is low, the CT is normal, but the A5 is 25. So she needed platelets and probably 2 units of FFP, two adult dose of cryo. But I think because she was going to be bleeding so much more, we also got some FFP. And then that's gradually treating her. And we actually gave her 23 small units of cryoprecipitate, I think 9 units of FFP, 2 units of adult dose of cryo, and she woke up the next day. So using the ROTEM algorithm actually helped with that. So and we'll leave it to questions for later on.
Okay, thank you, Dr. Kim. Thank you. And the last lecture will be Management of Failed Neuroaxial. And now Dr. Laura, I invite you to start the lecture.
Is this working? Is this one? Is this working okay? Yeah. Okay, hello everyone. My name's Laura. I am the Women's Anesthesia Fellow at the Women and Children's Hospital in Adelaide. Firstly, thank you very much for the kind invitation to speak here, and thank you for hosting us here at BICCM. So today I'd like to talk to you all about the management of intraoperative pain during cesarean. Is this working? Can you hear me? Thank you. I'd like to talk to you about the management of intraoperative pain during cesarean section, and I will also touch on some guidelines that have been quite recently published about the management of this. So to begin with, I would just like us to consider the term inadequate anesthesia for cesarean section and what we might mean by this. So there's no widely accepted definition, but I'm sure it's something that we've all encountered in our clinical practice and might have our own ideas of a failed regional technique. So this might involve inadequate block height, a unilateral block or a missed segment in the block, the patient experiencing pain or sharp sensations, or requiring adjuvant analgesia. But regardless of how you might define the term failed regional or inadequate anesthesia, the key factor underpinning all of this is patient distress and what the patient is experiencing. And this element is at the heart of the new guidelines that have been published, so I will touch on this later on in our talk. So as I mentioned, there's no widely accepted definition of inadequate anesthesia, but the key issue is the patient's experience and, most importantly, our response to that. If the patient is experiencing pain or distress and we fail to address that in that moment, then that can have a detrimental psychological impact on that patient and their subsequent pregnancies. An inadequate anesthesia can be detected either preoperatively or intraoperatively. The guidelines give some advice on how to manage these two scenarios because they will, of course, be managed in different ways. So there are some risk factors that might suggest which patients are particularly vulnerable to having a failed regional technique, and being mindful of these risk factors can help us to proactively manage our neuraxial anesthesia and try to minimize the risk of inadequate anesthesia. So preoperative risk factors include high BMI, patients undergoing their first cesarean section, fetal distress, as this will add to the urgency of the situation, any maternal medical conditions, again, operative urgency, and an opiate-free spinal. So we've already discussed a lot about the use of opiates in spinal, and this does actually reduce the risk of a failed neuraxial. Intraoperatively, the risk factors include duration of surgery, that of course is self-explanatory, and an inadequate preoperative block. Particularly epidurals that might be functioning suboptimally during labour and are requiring lots of multiple clinician boluses. And again, greater urgency of cesarean section, and also a non-obstetric or junior anaesthetist, which is a key factor, especially as we are commonly managing obstetrics out of hours. So there has been a recent systematic review looking at the incidence of inadequate anesthesia. In this systematic review, they defined it as the need to convert to a general anesthesia or to abandon or repeat your planned primary neuraxial technique, or giving intraoperative analgesia during the case. This systematic review looked only at elective cesarean sections, so that does miss out quite a high proportion of high-risk patients, but they found that almost 15% of patients required additional analgesia or anesthesia, which does seem, certainly from my experience, for elective caesareans, that's quite high. So this certainly is a problem with high prevalence. Fortunately, only a small minority, less than 1%, required conversion to a general anaesthetic. They did include patients who are experiencing pressure sensations, and I'm sure we're all familiar with trying to distinguish between whether a patient is feeling pain or pressure, but really what the guidelines in particular focus on is more important to manage what that patient is experiencing at that moment, rather than focusing too much on the exact nature of their symptoms. It was also found that epidural top-ups had a higher failure rate compared to spinal anaesthetics and CSEs. Oh, sorry. So now I'm just going to talk a little bit more about the recent guidelines that have been published by the Association of Anaesthetists of Great Britain and Ireland on the prevention and management of intraoperative pain during caesarean section. So they look at these different areas. And one important thing to note about the guidelines is that they were written with the input of a layperson representative who herself experienced a caesarean section under inadequate spinal anaesthesia. So as well as offering lots of clinical and technical advice about how to test the block and how to troubleshoot our block, it also focuses heavily on a patient-centered approach and the non-technical skills that we can use in these situations. So for the rest of the talk, I'll just focus on preoperative assessment of our block and how to take consent in obstetric settings, how to test the block, how to manage any intraoperative pain and distress, and then finally how to follow up our patients postoperatively. So looking at consent first of all, in obstetrics we're in the quite unique position of having to think about the health of the mother and the fetus, and this can affect our anaesthetic choices and our consent making process. Often we're in an emergency situation which presents a time constraint, and it's very important to have close multidisciplinary communication so that we can identify patients who are at high risk of needing a caesarean and making sure that we preemptively manage any epidurals that might be running on labour ward, or thinking about who might be difficult for a spinal anaesthetic. As with all our consent processes, we should include what the patient would reasonably expect to be told, and also be mindful that at this time, especially in an emergency, the patient might be feeling already very distressed, very emotional, and so this can affect our consent-taking process. And at this time, we have to be very mindful of the patient experience, and the guidelines talk about the importance of the role of the anaesthetist in establishing a good patient rapport and helping them to feel at ease in these situations. So our communication with the patient can really help reduce anxiety and improve their overall satisfaction. We need to consider any previous experiences that they may have had, traumatic birth experiences, previous caesarean sections, and also the current situation that we're in now, whether that's an elective or emergency setting. We also need to bear in mind that this is part of a significant life event for the patient, and some women do report feeling a loss of control in these emergency situations. So they're very vulnerable at this time, and it is essential for us to establish good rapport with them. The guidelines go into a few different ways in which we can do this, using both verbal and non-verbal communication techniques, being careful with the language that we use, making sure they understand everything that we are saying, and as with all communication, to demonstrate empathy and listen actively. It's also very important to legitimise the woman's concerns, whether this be preoperative or intraoperative. So moving on to how we can test our block. So this should be a multimodal assessment looking for sensory, motor and sympathetic block. We can test sensation to light touch, but also to cold or pinprick sensation, aiming for a block to the T4 dermatome bilaterally, ideally, with a sensation lost to light touch is normally a dermatome below your loss of sensation to cold. We can assess motor block in a number of ways, but quite a simple way to do this is to look at their ability to straight leg raise, and an inability to do this suggests a block of L1 to 4. Ankle dorsiflexion, it suggests that if they can't move their ankles, that suggests a sacral block, and sometimes with epidurals there can be sacral sparing, so preservation of that ankle movement. Sam has spoken extensively about the sympathetic block that can occur after a spinal anaesthetic. This isn't enough of an indication on its own of the efficacy of a spinal block, but it can be used helpfully in amongst the other signs as well. So we can look at a drop in blood pressure or increased temperature due to vasodilation, which would suggest a block to T10 at least. Throughout testing our block, it's important to have good communication with our patients so that they understand what it is that we're asking of them and that they feel empowered to answer honestly about what they're feeling. And throughout all of this, we should document the modalities that we're using to test our block, the time at which we're testing it, and in the case of using an epidural, how good the block is before we start. So the guidelines go into some sort of pragmatic top tips for testing the block, which I think are really helpful, and they've certainly helped me change my practice as well. So they suggest waiting for evidence of a motor block before checking for your sensory block, and throughout your practice to check your spinal block at quite regular time intervals. And this helps you become more familiar with what you expect to see at 5 minutes, 10 minutes, etc. And it also helps you proactively manage any blocks that aren't progressing as you would expect them to be. If you've got a dense block on one side, then it's better to start testing on that side so that the woman can really appreciate what it is that you are expecting her to feel, and she'll notice any changes on the other side. In terms of your timing for your block check, it's important to not check it too soon, because if you check it too early and there isn't enough of a block, this can reduce confidence in the spinal anaesthetic. But you also can't leave it too late, because you want to check your block early enough that you can implement any positional changes that might be helpful in getting that block to spread. You should also continue testing past the initial level of sensory change. So especially when you're testing for loss of sensation to cold, you might notice that the patient starts to feel something cold, and then if you continue testing in a cephalad direction, then that sensation will become icy. So there are also some common pitfalls that can affect our block assessment. So this includes the time pressure, particularly when you're in an emergency situation in theatre, everyone's waiting, the obstetricians are scrubbed, they're ready to start. You're feeling the time pressure, the patient is likely feeling the time pressure, and that can really affect a thorough assessment. The guidelines also pick up on the power of suggestion. So as I mentioned before, the patient is in quite a vulnerable position. They might be aware of a sort of hierarchy between us as the doctor and them as the patient, and they might feel like they kind of have to go along with what we say. So we need to be really careful with our language, not to ask any leading questions, but to ask open questions and allow the woman to express any concerns that she might have. And again, just being aware of the distress and distraction which might affect a patient's ability to understand what you're asking or to notice those different sensations, and that they might be feeling very anxious as well. Spoken about the hierarchy, but also we need to be careful of our own confirmation bias. So just because a spinal was very easy to perform, just because we might like to think that our spinals very often work, it doesn't mean that it will work. So we just have to be careful of that. So moving on to intraoperative management, we need to be aware that block adequacy can change over time, particularly in operations that can be prolonged for whatever reason. And the patient is the best monitor throughout all of this. So, keep looking at them, be aware of their body language. And more than the painful sensations themselves, it's actually the delayed or inadequate management of these sensations that cause the most patient distress. So prompt management of any kind of pain or discomfort is the most important thing we can do in these situations. And failure to do this does have a significant risk of postnatal psychological trauma. In managing any intraoperative pain, we need to consider the urgency of surgery, the nature of pain, and what stage of the procedure we are at. So this is kind of like a step-by-step process that we can use if we have a patient who is experiencing intraoperative pain during a cesarean section. The first thing to do is acknowledge what the patient is experiencing and make sure that she knows that you are going to do something about that. You also need to inform the rest of the team, as this will guide your further management. If it is safe to do so, you might be able to ask obstetricians to pause surgery and at all times keep reassuring the patient. Then we need to figure out what we're going to do. And this will depend on the time. So can we consider an alternative regional technique or extending our existing regional technique? Or do we have to proceed to a general anesthetic? If the operation hasn't yet started and you've performed a spinal and you feel like you've given it adequate time, it's not working, then you could think about performing an epidural or perhaps a CSE. If you've been using an epidural, then you can think about topping that up. And if we are intraoperative, then perhaps our next step would be to do a general anesthetic. Before we get to that point, we can think about some adjuvants. So nitrous oxide is very commonly used and can have a good effect, but it's unlikely to be sufficient in itself. We can think about giving IV analgesia. So things that we would commonly use and that are recommended by the guidelines would be short-acting opiate boluses, such as alfentanil or fentanyl, being mindful of any effect that this might have on the fetus if this is prior to delivery, or also boluses of ketamine. All of these will require close monitoring of the patient's sedation level and respiratory rates. If you have an epidural in, then your options are, you've got a few more options. You can think about topping it up, and it is recommended to use something quick acting such as lignocaine with adrenaline. If possible, minimizing surgical stimulation will help as a temporizing measure whilst you just gain some control. And throughout all of this, it's very important to document what management steps you have taken and what the response to these has been, and any discussions that you've had with the patient, particularly around proceeding to a GA. At any point, if any of these options fail, or if the patient requests it, then we should really be thinking seriously about proceeding to a GA and thinking about the ways we can make this as safe as possible. So moving on to post-operative management, follow-up is very, very important to try and minimize any long-term psychological impact that this might have. Ensure that the whole team are aware of what has happened, as this woman is likely to be managed by other people, midwives, throughout her hospital stay. She should have prompt follow-up, ideally by the same anaesthetist who is in theatre with her. If she requests another anaesthetist, then this, of course, should be facilitated. And if the case was managed by a junior, then ideally a senior colleague should accompany the junior for the debrief. The most important thing that we can do is just listen to the patient and really accept their account as the true account of events. So of course we can explain possible reasons for what has happened and our rationale for the steps that we took, but it's very important not to express any doubts at any point that what she is saying is true, because that was what she experienced. It's an opportunity to answer any questions that she or her partner or family might have, and to offer further follow-up, particularly if she's planning pregnancies in the future. And then written documentation throughout all of this is crucial. So thank you very much for listening. These are the references to the guidelines that I've mentioned and to the systematic review. If you have any questions, then I will be happy to try and answer them. Thank you very much.
Thank you, Dr. Laura. Oke, sebenarnya waktu kita terbatas karena jam 14.30 para speaker sini sudah harus di depan. Dan saya berikan kesempatan mungkin satu aja pertanyaannya. Satu pertanyaan kepada guest speaker. Kemudian mungkin waktunya kita paling tidak mungkin 5-10 menit paling lama ya. Mungkin ada pertanyaan, silakan. Mungkin satu pertanyaan pamungkas. Ada yang mau bertanya? Silakan. Pertanyaannya singkat, padat, jelas.
what's the availability of cryoprecipitate? So is you've so but it's a I under so is because I'd be in an obstetric hemorrhage, I'd be pushing to get focusing on having cryoprecipitate over FFP. That's what I'd be concentrating on, changing it to get cryoprecipitate there over the, and also particularly if you've got ROTEM in your theatre, and then that's actually because you'll be able to get your ROTEM result while you're trying to organise it all, and that will actually guide you. Because if you use an algorithm, the algorithm will say, yes, I need more cryoprecipitate, and it may actually indicate where the FFP might be needed or whether you need platelets. Because, and I can see where you've got a bit of a delay in getting blood products, the ROTEM is going to be useful, potentially. So there's a bit of a change, but people have to understand how to use it. But the other bit is stopping the bleeding, and I think the surgeons, the obstetricians here will move on to doing a hysterectomy earlier, because you do not want to get into the coagulopathic. So getting the obstetricians, and you can if they're, being prevaricating, you could actually say, how about doing, or the other thing is about stopping bleeding, is putting aortocaval compression on. So that's not, you don't just use, that's actually a really useful thing to do. And that's what we did with that other case that I was describing. And the bit about using tranexamic acid, not just one dose, but using another dose. Is that okay?
I think certainly in the Western world, every place that brings in ROTEM or thromboelastometry or elastography, as Kim alluded to, you see a very consistent change in transfusion management over 6, 12, 18 months, with a big reduction in FFP use and an increased use of fibrinogen products, whatever that is, whatever you've got. That's a very consistent change across the UK, Europe, and Australia in our department as well. And that reflects on some level, it reflects the coagulation cascade, and that you can lose 70 to 80% of your clotting factors and still have some clotting factor effect based on the thrombin burst and the way that the pathway works. So you don't get a lot of value from using FFP in bleeding. If you lose 70 to 80% of your fibrinogen, you get a hemorrhage. And that's why transfusion management changes when you use ROTEM, because you start to see that. You start to see the value from fibrinogen products rather than FFP. And if you can't get fibrinogen concentrate or cryoprecipitate currently, then 1:1:1 is pretty established. It's pretty safe, and it's an as good alternative to ROTEM-based transfusion management, I think. It was interesting what you said yesterday, Cindy, about whole blood, because whole blood actually has a lot of value. Particularly in resource limitation. Dave was talking about this in use in the military. But there are these very consistent changes that you see when you bring in ROTEM, which just reflect underlying physiology, probably more than anything else. And if you've got them available, fibrinogen is the best option, just reflecting the reduction in fibrinogen versus the reduction in clotting factors.
We're really clear, and then we audit it. So we've got the parameters set up when you can use fibrinogen, because it costs us $5,000 and Yeah, because it cost us $5,000. Yeah, so that's. Yeah, exactly. So that's why, but using the other, you know, if you can get the cryo.
I think you guys doing the best you can, basically, you know, with the available resources. I think I think we'll be very, very concerned. Like, you know, if it was us, I think all of us would be very, very concerned with doing this, because we sort of way out of our comfort zone with that what you are having. But I guess it is what it is, isn't it? So if you don't have cryo, what to do? That you need to do whatever is available with an FFP. The next best thing is FFP. So what in your scenario, what happened was, like, you know, you get about 10 liters of crystalloids, isn't it? 10 liters of crystalloids and 4 units of blood, and then probably 3 units of cryo is what you'd get. Well, 3 units of FFP is what you're given. So the patient would have had severe dilutional coagulopathy. She was bleeding and bleeding and bleeding, wasn't she? She's just oozing all. So the reason for that is dilutional coagulopathy. You can get 10 liters of fluid in a patient who's had lost almost 5 liters, and you're giving 4 units of blood, PRBCs. Where are the factors? Everything is diluted. So all your fibrinogen is got consumed. Fibrinogen, it's all cascades down to fibrinogen, isn't it? So all your fibrinogen is consumed. So that's what Kim and everyone is trying to tell you, that you need to push for having fibrinogen, so that it comes in. And you already, so FFP's got some fibrinogen. It's not like, you know, as Kim said, it's not coming from a pregnant patient. It's got some fibrinogen, but it's not as power packed as your cryo. Do you know how much a cryo comes in? It comes in 30 ml bags. 20 to 30 ml bags. So one adult unit, you give it, will be about 80 mils. So you're not diluting the cryo, diluting the fibrinogen inside the patient. So I guess what happens in an elective scenario? Can you, if you have a patient like that in an elective situation, just like that was an elective surgery, isn't it? Can you have cryo beforehand? Like, you know, if you have time, would you be able to arrange cryo in these patients and have a stock? What's the I don't know, I'm sure there'll be costs involved and all those things. What in an ideal scenario, would you be able to arrange some cryo beforehand if you think that this patient is coming electively for a surgery? You can, yeah. So it's worthwhile when you're doing cases like this, worthwhile having some cryo handy before you start embarking on that case, because you know these cases. So have a chat with the obstetricians. All this. And we need to have a multidisciplinary involvement, which you guys are doing anyway. You'd know that beforehand, and then prepare your theaters first. Like, you know, if you happen to use it, it's good. Like, you know, if you don't want it, then someone else can use it. That cryo can be used for someone else. So probably develop a resource of cryo happening like this. And if you use it as a bonus, like, you know, the last thing, you know, there's time. So think ahead. Get some cryo handy. Let's 1 dose or 2 adult dose of cryo handy. This might save a life if you have time, and if that involves, it doesn't involve much of resources and stuff in an elective situation. If you don't use it, then you can use it for the next patient. The blood bank can always store it.
Yeah, like FFP, cryoprecipitate is frozen for a long time. But then when you call for it, they need to thaw it. So that'll take a half an hour to thaw it and then transferred to theatre. And there are issues about the plastics that it's stored in to prevent it from cracking. That's a lab thing.
Almost 90% of our bleeding with coagulopathy is treated with cryo. I can't remember the last time I gave FFP nowadays. Like, seriously, like, you know, hardly give FFP these days, because that's what you need there. Obstetric bleeding, you get consumption coagulopathy, and everything just falls, cascades down to fibrinogen. Your fibrinogen gets depleted, and almost 90% of the time, the treatment is cryoprecipitate or fibrinogen concentrate. So that's why we're emphasizing on get, like, you know, at least in elective scenario, explore the possibility, have blood and cryo ready, just like having your RBCs ready. Have some, talk to the blood bank and have some cryo ready as well.
Yudi, were you in theatre for that case? For the whole 7.5 hours? Was that, what kind of day was that for you? that's a really long day. You have my absolute sympathy and credit. That's a really bad day in the theatre. And I think it was a bit difficult to tell, but she ended up having a caesarean hysterectomy. Is that right? Yeah. So she had a creta, which she knew about, and then developed significant bleeding that needed that you needed to have a Caesar hysterectomy. The obstetrician did a Caesar hysterectomy. Yeah. So from just picking up a few things along the way here, you guys are going to be you're going to be seeing that way more frequently than we will in Adelaide. And I think that's something that you as an anaesthetic department can work and collaborate with the obstetricians and gynecologists, because you're going to start seeing, just with the caesarean section rate and repeat pregnancy rate, I think you're going to see a lot of accreta and abnormal placentation. So that's something that you guys could work together, because while it's a bit more elective than, this one sounded like she started bleeding like late in the evening, and then you had to, it wasn't purely elective. She was in hospital because she started bleeding heavily. Is that right? It was elective. Oh, okay, sure. Yeah, but yeah, and maybe plan ahead. But that's something you guys can work together with, because you'll start seeing this more frequently. I think they're a very challenging case, and you can't keep spending 7.5 hours in theatre every time you see an accreta. That would be absolutely tragic. So this is a little token of our how impressed we are. So don't eat them all, but share them around. But that's an incredible presentation. Thanks, Judy. That was great.
Okay, thank you. I apologize, the time is up. We have to close this discussion session. Now we have reached the end of the guest lecture event. I would like to thank you all, the guest lecturer, for having shared your wonderful knowledge and experience. We have received great benefit. I hope we can continue this valuable event in the future. Thank you and God bless you.
Rotor Sigma is a machine developed to monitor the clotting process. It's performed to optimize transfusion decision in major surgeries and traumatic bleeding scenario. Rotor provides a global assessment of hemostasis by using a saturated whole blood sample.
So first I'm gonna show you the parts of the machine and the consumable. A large integrated touchscreen allows easy viewing of results with a barcode scanner to scan patient ID or QC reagent. Here is the main switch on-off button and the USB port for the export of data. The system QC cartridge is located on the right side of the device. A printer which is connected to the system allows to print numeric results and tomograms. Now let's move to the consumables. The cartridges are stored at room temperature, and rotor QC reagents are stored in the fridge. So first we have to switch on the machine by pushing the button on the right side. After user login, the rotor measurement menu opens automatically. We start with System QC for device check. In every step, we have to follow carefully the instructions on the screen. Insert QC cartridge and wait until the test is done. Remove the cartridge and replace it in its slot. The system test should be done daily according to the BOCT recommendations. First, take out one level of QC material, roll N or P, and let it reach the room temperature. Dissolve the content of Rotrol B by pouring the vial with diluent. Gently swirl the mixed content to dissolve it for 5 to 10 seconds. Set a timer and wait for 15 minutes. Before use, gently invert the vial 10 times. Press Start Rotrol and scan the Rotrol vial. Open the pouch and insert the cartridge in the device. Insert the Rotrol vial firmly into the cartridge. Let the QC measurement run until parameter A20 has been reached. Once QC results show for A20, select Stop All and save Clear All. Remove and discard cartridge in the yellow bag. Repeat the same steps to run the other Rotrol QC.
Remember, it's very important to use citrated coagulation tube, the blue vacutainer, and the amount of blood we need is 2.7 ml.
Log in with your username and password and make sure device is ready for processing patient sample. Press Start and insert the cartridge. Scan the patient ID and confirm it on the screen. Mix the patient sample gently. Insert firmly the patient sample into the cartridge. The measurement starts automatically and result will be displayed on the screen.